is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound.
Okay, good morning, members. We have a quorum now, and I call the meeting to order. And the meeting is now open to the public online. And I'd like to welcome all members who are participating by video conferencing and remind members about the protocols regarding the use of electronic devices. Members, further consideration stage of the Preservation of Documents Bill is due to be at some point this morning. Indicative timings at this time are 12:30. If necessary, therefore, we will suspend the meeting to allow members to participate at further consideration stage. So, members, in light of those time pressures, what I will propose doing with members' indulgence is that we go straight to the briefing from the Minister and Permanent Secretary, and we can then return to our agenda items in turn following that session. So, just checking, first of all, Minister, are you able to hear and see us there okay?
I can, Chair, yep.
Yeah, and Permanent Secretary Richard, can you hear and see us okay?
I can indeed, Chair, thanks.
Yep. Okay, thank you. Minister, then, do you want to go ahead with the opening remarks, please, and we'll take it from there?
Certainly, Chair, and thank you. And I'm sad to say, Chair, that this will be the last briefing that I'll be able to give to this Health Committee in this mandate, but I would like to start by thanking yourself, Chair, and all the members for the support that they've given me as Minister in the Department through what has been difficult times that we've had, especially over the past 2 years due to the pandemic. And I know it hasn't been without its challenges, and I thank the committee because this committee has had to consider the full breadth of COVID regulations on top of your own extensive workload, and I really appreciate the collegiate approach that we've all been able to demonstrate, and that has been in the responsible face of the Assembly that the general public want to see when we do come under that pressure. And I think it was only fitting that we took the time actually yesterday to reflect on the challenges and losses of the last 2 years. And I think while we're thankful we've been able to move beyond the blunt use of restrictions, it's important that we continue to guard against complacency actually regarding the virus. And I know that's a view shared by the committee as well. Yet, I'm glad that despite all the challenges of the pandemic, we've been able to make real progress on a whole range of issues. So I also want to thank the committee for your constructive scrutiny of our organ donation, adoptions and children's, and the health and social care bills. These weren't straightforward bills, and I know myself the amount of time and resource it takes to sit on the committee, to hear evidence and then consider bills line by line. And I do really think each of the bills are all the stronger for our engagement together on that. But the committee will be aware of a range of strategies, plans and initiatives that have been announced over the last 2 years as well. Whilst thankfully we're in a much stronger workforce position, both in terms of numbers being trained, but also importantly morale than we were in January 2020. There's still obviously much more work to do. Yesterday's announcements, for instance, for additional GP training places, I hope will be followed with further increases in the years ahead. On our waiting times, the elective care framework provides us a real roadmap ahead. But importantly, I've always made clear that it wasn't just to be a strategy for a strategy's sake. It needed clear, key measurable actions and a way of closely monitoring its progress. So last month I published the first interim report, which provided an update against each of those action points. So the progress has been made with the publication of the mental health strategy and importantly delivery of commitments within the mental health action plan before it. Members will also be aware that this week I was able to publish the cancer strategy, and in the announcement the identification of White Abbey and South Tyrone hospitals as the locations of our first 2 rapid diagnosis centres. So as we continue to deal with the realities of the pandemic and the pressures That already existed across the health service even before it. I think we can all agree that we also need a firm focus on recovery and improvement. And I've no doubt that whoever sits in this chair in the months ahead will want to see the existing momentum continue. So whilst we're constantly planning for the future, the pace, scale and direction of rebuilding and transformation of the health service will also be influenced by the resources that are available to it. We had a real opportunity with the 3-year draft budget, and whilst that has admittedly been lost now, with each and every day since I've been bitterly disappointed about it, it just makes it all the more important that the next executive agrees a sustainable multi-year budget position. So, Chair, just in summing up, whilst there has been progress made, there's still much work for the next Minister and the next committee to do. And I hope that the next Minister and the next committee can work in the collaborative way that we've been able to do over the past 2 years. So, Chair, I had a brief opportunity, just for a few opening comments. I'm happy to take members' questions or comments.
Okay, and thank you for that, Minister. And I do agree and acknowledge that it certainly has been very difficult and a challenging times. And I do think that the committee and yourselves have worked well on particular issues and have worked in a constructive way, which I think underpins all good engagement. So thanks for that. Okay, Minister, moving on then, because I do want to get to members' questions, I suppose, as quickly as possible. The first one for me is around the issue of mileage for all those staff who are travelling out and around on the roads. We are all very conscious of the fact that the system as it's set up finds many of those staff who are travelling a lot of miles as a regular routine part of their journey. Their pay drops substantially, their expenses drop substantially, and many of them have been on that reduced mileage allowance for a long period of time. Given the pressures of that, the pressure of the work that they have to undertake, and the very serious rises there have been over the past number of weeks, is there something concrete that you can commit to today that will provide those staff with additional support to cover their expenses? Staff who we know on some occasions are actually having to turn down shifts as a result of not being able to afford the fuel for the car.
Chair, unfortunately there's nothing concrete I can give you today. I wish there was. I was hoping, although the announcement by the Chancellor yesterday in his spring statement was welcome, I don't think it went far enough in addressing the general needs of the populations across the United Kingdom, not just our health workers. Our unions have spoken with Staff Council to raise, that's at a UK-wide level in regards to this specific issue. I've asked officials to see if there's anything we can do in the short term locally in regards to where we are, but as of yet it's still a scope and exercise, Chair, but it is something that we're actively considering. We're considering how we can support those staff, because the points you make are valid and the concerns you raise are shared, not just by myself but those working across the trusts who need to ensure that those shifts, those care home visits, those domiciliary care visits are actually covered as well. So it's work that has been undertaken and looked at in regards to what we can do. The unions, as I say, have actually are active and engaging with Staff Council as well to see what can be done at a national level as well.
Okay, thank you. And that maybe brings me on then, and I would welcome anything that you can announce over the course of the next wee while, because staff are clearly feeling that pressure on a daily basis. The other one then that I wanted to come to was on the workforce issue, and one thing I do want to maybe diverge slightly from you on in terms of your opening remarks is around the morale and the pressures on workforce. I am hearing from certain cohorts of staff that morale actually is quite low. They feel under significant pressure. They feel that there's not a full understanding of how bad those pressures are. The pressures are clearly being reflected in the system and throughout the system, where we see, overcrowding in EDs, that then leading to the very unfortunate inability of ambulance staff to discharge patients, and we know the impact that's having on patients and on staff. We have the issue of GPs, we have the issue of multidisciplinary teams. All of those are all workforce issues, and workforce is the central thing and the barrier which we keep returning to. So, in terms of funding and planning, are we at a scale of dealing with this, the workforce issue, in your view, which would underline the urgency of getting those additional staff out into the community that we largely know are needed? For a start, there are active gaps within the workforce, and then there's the planning for the population and what we actually need. So, is there a clear measurement at this point in time of how many staff in each of those professions we need now, in the next 5 years, in the next 10 years, to deal with the health needs of the population?
The workforce, I suppose the workforce strategy 2026, delivering for our people, actually covers a lot of what you're addressing, Chair, but it is that long-term strategy. And I think, as we've always said, when we look at those gaps within our workforce, there's a time lag to be actually being able to announce that we're increasing those numbers as to how they actually go through their training, go through their positioning as well. So there's large challenges in the short-term fix in filling those gaps, those recruitment processes. And I've said this before, Chair. I think one of the main, the biggest gains that we got when the executive returned in January 2020 was those additional 300 nursing training places for 3 years. But as I've said, we don't see those nurses actually starting coming out into the active workforce until even later this year to the start of next year, and that'll go on for another 3 years. And in the same regards, the 10 additional GP training places that I announced yesterday, again, will take time, but it's about those announcements, those indications to the workforce that we're serious about addressing the workforce shortages that we currently have. It's also how, again, we start to look at our international nurse recruitment, and we're looking at those across different fields than we had in the past, rather than just simply adult nursing. So we're now looking for the international recruitment field for mental health nurses, for children's nurses, and other aspects as well, something that we haven't done in the past. But in regards, and you'll have seen, Chair, reports from the World Health Organization, the shortage of health workers isn't just a Northern Ireland phenomenon on its own. This is a worldwide shortage that we're now experiencing as well. So that's why it's important. It's always been important for me that we train and grow our own. So the workforce strategy that we've seen coming in for especially our domiciliary care workers and our social care workers, where they can actually progress up through. So again, the open university posts that allow that workforce to develop either through nursing side or actually into social work side as well. So there's a number of avenues, Chair, but in regards to workforce, there is no quick fix. And what we're now reaping is those 10 years of single year budgets, which hasn't allowed the number of training places to be embedded, because with every training place that is committed to, there's a 3 to 5 year budget ask that comes along with that as well. So I don't want to keep repeating the issue, Chair. The 3-year budget and that ability to plan over that period of time would really have given us a different ability to look at how we actually plan for workforce. We're aware of the challenges that are out there. In my opening comments, Chair, I did refer to the morale of staff and how it was different from where we were in March 2020 when we first were experiencing this outbreak. So I don't want just maybe those comments to be confused, that there isn't a challenge in regards to where our current workforce is, because I'm fully aware of the pressures that they're under. Okay,
thank you, Minister. And in relation to, and you've touched upon it there, the 300 additional nursing places, and we're acutely aware of the pressures within nursing. Can you commit that those 300 places, we're in the final year of the 300 additional placements, can you commit that those 300 additional places will continue beyond the initial 3-year period?
I can't, Chair. I don't have the budget commitment to be able to do that. I wish I had. I wish I could, because I know we do need them. New Decade, New Approach allowed for that 300 for the first 3 years to get us into a position where we were almost treading water in regards to our nursing numbers specifically. And you do remember, Chair, that one of the bigger pressure points actually for the return of the executive in 2020 was the fact that our health workers and our nurses were on strike and in taking industrial action for the first time, I think, in 100 years of the RCN's existence, which should not go unrecognised and uncommented on either. So we don't have the financial surety to be able to do that. Again, it's a decision that will have to be taken next year, because we are, the cohort of those additional 300s is still within this year's incoming budget, so we do have the certainty of that.
And in light of that, Minister, are there ongoing discussions with Rishi Sunak and with the British Treasury around the funding package that's available in terms of transforming our healthcare, in terms of addressing what is a workforce crisis? Clearly we will need, and I do get your point, and I agree with your point around the 3-year budget, but as well as that, we need to see significant ramping up of recruitment, as you have said there, to fill those places. Are there discussions going on in relation to that with the British Treasury?
Well, Chair, I think you touched on the point, and it's one of the things that with the executive in Northern Ireland in regards to the conversations with Her Majesty's Treasury is actually a discussion that the Finance Minister has. And I think he shares the frustrations, and he's articulated the frustrations in regards to the lack of the 3-year budget, or even the draft budget that went or was going to go to public consultation a few months ago, which would have seen an increase in the allocation to health. It wouldn't have met every need that we had, but it would have went a considerable way to allow us to make those more strategic decisions, the transformation decisions that a certainty of a multi-year budget would have given us. So at this point in time, Chair, we're fully aware of the additional £300 or £300 million, apologies, that the Finance Minister currently has, that I know the SDLP were looking through private members' bills to be able to allocate, but just in the situation that we currently are, the financial pressures are something that's actually affecting all departments across the executive, not just health, but we are feeling them more acutely, because we were looking to a significant increase into our budget would allow us to have completed a lot more of the transformational work and given a lot more surety to our workforce that multi-3-year budget would have given.
Okay. Two final brief ones from me, because I do want to get to members, and members will cover probably in more detail some of the issues that's being raised now. First of all, on the daycare and respite settings, which we have spoke about many times, and you will be aware, actually, Minister, a specific case of the Firs residential home in danger of closing as a result of the owner needing to retire. But also that is the only daycare provision and respite provision in the Clare Valley. At a time when daycare and respite have not been restored, could I ask you to commit to doing everything in your power to making sure that we don't lose a very, very valuable and a very well regarded setting in that area? But also, can you give us a date as to when trusts will restore to 100% the daycare and respite facilities that people so badly need and have been assessed as needing?
Yeah. Chair, in regards to this, and I know you mentioned Firs, and I think you actually tabled a petition in regards to this, so I know it's a constituency issue for yourself and something you've taken active consideration, and there will be a written response in regards to your petition will issue, so I don't want to get into the details of a specific unit here today. In regards to the formal pathway of reopening care and respite facilities, I actually made the announcement, as you're aware, on the 31st of January, that the Public Health Agent pathway had published to remobilise our respite services, and trusts were to use that pathway as the enabler. So throughout February and March, my officials in the trusts have worked together to deliver those draft rebuild plans and indicative timeframes to restore daycare, short breaks and transports. So again, the Health and Social Care Board and its successor has been tasked to make sure that priority maintains. Our Chief Social Work Officer is now taking personal active lead in re-establishing all those facilities, and we're looking to a formal review of the implementation and an update on that within the next few weeks as to how that is actually performing, not just across all trusts but across all facilities as well. Because one of the things that I want to do, Chair, as well, is once we do get all these facilities open and up to 100%, that we make sure we can keep them open to that level of delivery and service as well.
And have you given the trust a deadline to respond, or where you've said a few weeks there? What is your target date for having them reopened?
Well, the target date is for the formal review of that implementation pathway will be taken by the end of April, in regards to where they currently are. And as I say, the Chief Social Work Officer is now taking a personal lead in regards to that.
Okay. Okay, the final one for me, Minister, and I do want to welcome the announcement yesterday on the MDTs. However, I want to focus in on when we can actually expect to see that recruitment process starting and those to be rolled out. I particularly welcome the fact that the South West area, which has come under significant pressure, and there are GPs at significant risk, that will be one of the priority areas. What I was looking to ask is, when can we expect to see the MDTs being recruited and put in place in those areas?
Well, Chair, the next three that were announced, as you indicate, were North Belfast, the South West area, and East Antrim, and that's where the project board we're seeing the next available steps. Now that they have been announced, it's about securing again the interaction between federations and trusts to get that recruitment process up and running and financed as quickly as we possibly can. In regards to that, we'll look to the deliberations of the next budget as well to make sure that there is surety and long-term commitment to those posts. But again, Chair, and it almost goes back to one of your earlier questions, and that's in regards to workforce. One of the things that we also need to be aware of in the regarding the establishment of MDTs is that simply we don't move professionals from one location to another and then actually remove a service from somewhere else to replace it in a different location. So there's a collaboration now between those three GP federations and the relevant trusts in getting those up and running as quickly as we possibly can. The announcement was made yesterday. I made that confirmation yesterday in regards to the next three, Chair. So the trusts and the GP federations will now work through their timeline as recruitment and the establishment of those. But as you rightly indicate, not just the South West, but North Belfast and East Antrim, those federations have been assessed as the next three that are most in need of the establishment of MDTs, because we have seen already the benefits that they are bringing in the other five fully and partially rolled out areas from the collaborative work, and that they do bring of that of having social workers, physiotherapists and psychologists all available through our GP practices.
Okay. I'll go across to members then, Minister. So I'm going to go first of all to our Deputy Chair, Pam Cameron, and then I have Deborah, and then Paula, and then Alan. Yep, go ahead, Pam, please.
Thank you, Chair. Good morning, Minister and Permanent Secretary. I wanted to ask you, first of all, Minister, around if you could give us an update on the bed capacity at the Antrim Area Hospital site. You'll be well aware that Antrim is continuously struggling due to the fact that they simply don't have enough beds. Very ill patients in. I have raised this issue before, and these beds can't be created overnight, and the action needs to happen now in order to ensure that those 48 extra beds that have been requested are in place for the worst of the winter pressures to come. But can you update us, first of all, on that capacity issue, and assure us that that will be addressed with the utmost urgency, please? And then I've got a couple more questions. Thank you.
No problem, Pam. No, look, in regards to those 48 beds, the Northern Trust is currently working up an option to get those 40 beds on site as quickly as possible, and it's actually through a different funding arrangement that we're actually looking at as a new system. So it needs to be they actually need to rework their current business case. So I've actually asked that the Northern Trust can get that again to us as quickly as possible. Again, if the business case is completed and with us in March, where I can make a decision. If not, that we'll have it in place for the next minister coming in. But I'm conscious, Chair, of the Permanent Secretary on here. Maybe want to bring him in just to answer something, just in case he feels left out in regards to this morning's meeting. Maybe Richard, if you want to comment to that.
And just to advise, we're not seeing Richard on screen, so just to let him know that.
Oh, sorry, Chair, I'm not sure what's wrong with the technology of my camera on, but can you hear me okay?
We're hearing you yet, but still not seeing you yet.
That's maybe not a bad thing for you, Chair. I just, in terms of the Minister's comments, I spoke again to the Chief Executive of the Northern Trust this morning, Jennifer. The Minister, as he's indicated, has been pressing both ourselves and the Trust to accelerate all the work in terms of the bed capacity. Over the last couple of days, a potential more rapid solution has emerged So the Trust are looking at that with all urgency, and even later this morning, the Trust Finance Director is meeting some colleagues in the department to look at that. It seems that the original 48-bed proposal, given the normal requirements about procurement and construction, the Trust is actively exploring another option that could guarantee something being on site for the start of the winter 2022, which is the time scale that the Minister has set out that we need to try and alleviate the stresses and strains on the entrance site. So that work is continuing with some urgency, and we'll accelerate that as quickly as we can.
Okay, thank you. Pam, go again.
Yeah, thanks, Chair, and thank you, Richard and Minister, for that response. And I hope that everything that can be done will be done in order to help the Trust actually get through this and get those beds in the planning system and in place for the winter. Minister, could I ask you if we can get an update on the progress in relation to the elective care framework? And could you also tell us what bids the department have made in terms of the £300 million unallocated by the Executive?
Thanks, Pam. I think, as I said earlier, in regards to the elective care framework, I did publish a 6-month update towards the end of last year, in regards to the end of last month, just in regards to where each of those, each of the targets and each of the action plans have. As the 31st of December, we were, I think the actual numbers I'd give to Patsy McGlone in an assembly question, we had still 147,800 patients waiting for diagnostic service. 83,000 of them were waiting more than 9 weeks for a diagnostic test. 49,600 waiting more than 26 weeks. We've still 120,000 patients waiting for inpatient day case treatment, and over 97,000 waiting of those waiting more than 13 weeks. So our elective care framework and that strategy is, unfortunately, we're still seeing a slight increase in those numbers. But if we weren't having those initiatives of the mega clinics, of the rapid assessment units that we're using as well, they've been an awful lot worse. In regards to the 300 million that is sitting there, that unfortunately we can't get allocated because there is no functioning executive, I actually had put in an ask to the Finance Minister for 23 million, and that would allow us to roll over those elective care initiatives for the first 3 months of the financial year, in regards to what we need to do, because that's the tail that we need. If I don't have the surety of that money, it's the like of the utilage of the independent sector we're using, that we won't have the ability to actually bid or book operations and procedures through that, which is part of the elective care framework as well. So it's that an initial ask in regards to allow us to keep doing what we're currently doing.
So just for clarity there, Minister, thank you for that. £23 million bid, and that's in relation to elective care that would have been used for the independent sector to be paid.
Well, it's across all the elective care strategy in regards, but it would be only the 23 million would be for the first quarter of the new financial year in regards to where we currently sit.
And no other money bid?
Not for that 300 million, because of the assessment that was made of where it was actually being taken to alleviate both food and fuel poverty across the entirety of all the population of Northern Ireland. So we were being proportionate in what we were asking for from a health point of view in regards to that 300 million. But if there's more, and as you know, Pam, if it's not all used or not all bid for, we'll be able to utilise it. But we do need a mechanism where that 300 million pound is actually made available to government departments and ministers to actually utilise. So it's okay bidding for it. If it can't be delivered and the money can't be passed out to us to actually utilise, it starts to put additional strains on what we can do.
Okay, thank you for that. Can I, the final question, could I ask if you might want to give us some more information on the phased introduction of a new medicines adherence service in Northern Ireland as announced yesterday, and I welcome the progress that has been made on that. But if you want to give us some more detail around that.
Certainly, Pam, and thanks for that, Vice Chair. To be able to give some good news today as well in regards to this here, and you will be aware, and again it's something I know you've raised personally as the chair of the all-party group on community pharmacy. Through working with my department officials and the Health and Social Care Board and Community Pharmacy NI, we've been able to provide an additional £8 million for this year, which has seen the recommencement of that service for those patients who are coming out of hospital with a need for a managed medicine provision through their community pharmacy, as well as looking to how we continue that into the next years, into what will be the 3-year commissioning arrangement that we've been able to agree between the department, Health and Social Care Board and Community Pharmacy. Again, you'll be aware, and all the members will be aware of what I think has been again a very collaborative, productive relationship that we've developed with community pharmacy, especially over the last 2 years, from the delivery of services that they have been able to provide through the pandemic, through the supply of our vaccination and our booster programmes, as well, even to the additional delivery of flu vaccination as well. So it's a good, positive working relationship that we have. It's not without its challenges, but we're in a better place now to make sure that they're involved as part of the wider health family in regards to all the discussions and all the input that they can have and what services they can provide for us.
Okay. Appreciate that. Minister, and can I just say that I'm glad that productive relationship is there with community pharmacy, and that needs to continue, because I'm sure they are incredible healthcare professionals, and they've really shown their worth throughout the pandemic in particular. And I do understand that there are more things that they can do in order to help transform healthcare. So thank you for that. Thanks, Chair.
Thank you, Pam. Deborah.
Thank you, Minister, for coming to the committee today. I suppose my only disappointment is we're not going to be able to follow up all the discussions that we've had today, but I've always appreciated the time and the discussions that we have had during my time in the Health Committee, and it only feels like I'm getting started and I have to go. But in terms of yesterday's announcement, I was really, really pleased to see that the South West area, in terms of the MDT allocation, so thank you for that. And just following on from Colin, the Chair's questions there, in layman's terms, do we know yet what allocation of money these MDT announcements will receive, and do we even know in terms of the amount of GP practices that will affect?
Off the top of my head, Deborah, and I apologise, I know you've said we'll not be able to follow up in detail, but I think in regards to the South West alone, I think it was over 7 million in regards to the establishment of MDTs in the South West area. Again, I'll try to get you the exact figure in writing before we do close. But again, because the relationship in the MDT is across the Federation, so I think there's 30 GP practices within the South West area Federation as well that will have access to the ability to develop that MDT programme. Richard, I'm sorry to interrupt you, and you don't have that to hand, or?
Sorry, Minister, I don't have the exact figures to hand.
No, that's okay. No, Deborah, apologies, we'll get that. We'll get those to you.
Okay.
Via the committee, so that the access is there.
Okay, thank you. And you know, Minister, I've raised this a number of times with you and in the chamber as well, in terms of the worry and concern I have in the rural area for GP practices, in terms of retirements that are happening and the workforce there to fill those gaps. Now, I live in a beautiful place, there's no doubt about that, and it's a great place to live and to work, but unfortunately we're not seeing people being attracted, I suppose, to the area. And I'm wondering, do we need to have a bespoke package of measures to deal specifically in attracting workforce to the likes of rural areas, or across Northern Ireland?
I know, Deborah, it has been something has been discussed, but I think, going back actually to the Chair's point, our challenge is the undersupply of workforce practitioners should that be GPs, community pharmacy, nursing, across all those disciplines. In regards to some of the concerns that have been raised, if you put in incentives, which I know has been looked at and has been discussed, into one area, that it could entice actually displacement again, where you're actually taking away from one area. So it's about really increasing our workforce to meet the need, and also making those areas attractive to work in from a lifestyle point of view. And I don't know if you've seen, Causeway Hospital Northern Trust has done some fantastic recruitment videos on social media, promoting the entire area, not just the Causeway Hospital or the Northern Trust as a place to work. And as you say, Fermanagh and South Tyrone has that same offering as well. So again, it's about working through all the employers and with the employers to make sure that the health service as an employer of choice in that area, but also that your geographical area as a place to live, are both attracting as well. And that almost takes me back, to some of the challenges we've even had in the last number of months, where we've seen some elected representatives take to talk down either the hospital in their area or the work that the trust is doing in their area. It actually detracts from that trust or that GP service's ability to recruit, because people see it as not an attractive place to go to work.
No, absolutely. I couldn't agree more in terms of that. My last two questions are just around why is a new and comprehensive health and social care workforce plan not achievable until 2026, and also what work has been going on to deal with workforce pressures, indeed reducing the reliance on agency staff. And I know that may go back as well to, obviously needing staff there, but can you maybe talk around what work has been ongoing there in terms of agency staff as well?
Yeah, well, it's not achievable to 2026. The strategy itself that was actually published at that time was a Health and Social Care Workforce Strategy 2026. And it was a follow-up actually from the Professor Bengoa's report, which was the Health and Wellbeing 2026 Delivering Together. So the two strategies actually ran in tandem about what was meant to be done. There were meant to be three triennial reports. Now, unfortunately, one of those has been delayed or derailed due to the pandemic, but that piece of work is actually up and going again to make sure that we get on top of that. But again, it goes back to the point I made, the recruitment, the funding, because to announce even a one post, we need to make sure the funding's there to continue that through the entirety of the educational programme, should that be three or 5 years. So it's about the tail of funding this is there as well. In regards to agency spend, there is now an established unit or a group that is meeting within our workforce directorate looking at that, because it's something we do need to get on top of. But again, what we're seeing is because of the lack of our own core staff, agencies have the ability to and the necessity actually to fill some of those shifts to make sure that we can deliver the service we need. So we need the workforce to be able to reduce the amount of agency usage and the agency spend we do. So it's an ongoing piece of work, but we have to get people out of the colleges and the universities to start to regrow and recruit that gap of our own workforce.
Can I just very briefly come back on something there? Thank you for that. Just in relation to, you said there that there was a bit of a delay as a result of COVID in terms of the planning and things. So therefore, is there going to be, we're going to see delays in any of the implementation of any of that? Is that going to have a knock-on impact?
No, we didn't delay any of our recruitment programmes. They continued, so the places still went in. In regards to the workforce strategy itself, there was meant to be three triennial reports that come out to give an update as to where each of the tasks, each of the targets were actually at that point. So there wasn't, we didn't have the capacity either within the department or across the trusts for the second publication of that update, but that's what we're working to update as well. So recruitment continued, training continued, so there's no fallback there. It's just in the publication and the update of that strategy as a, I suppose, as a written document, Deborah, rather than any practical outworkings of that.
Yeah, thank you.
Okay. Thanks, Deborah. Paula.
Thank you, Chair, and thank you, Minister and Permanent Secretary, for coming today. 4 quick questions. First of all, you will be aware that the departmental officials were meant to be before us today to give us an update on the commissioning of abortion services. If you could give us an update on that. The second issue is in relation to the cancer strategy, and I applaud your team for that, in particular Gay Ireland. She has done an amazing job in pulling that together. But my questions in relation to the rapid diagnostic centres where there's referrals where they could indicate cancer. Are these going to be open to general referral, or and if so, are you planning these centres for the wider conditions, including rare diseases? Third issue is, are you planning to publish the 2019 consultation documents in relation to the stroke reconfiguration service consultation plan? And fourthly, where are we on the, and it wouldn't be the last Health Committee meeting, Minister, without me asking, where is the ME Regional Clinical Lead for Northern Ireland? Thank you.
Thanks, Paula. 4 very quick questions, but all very detailed in regards to where we are. In regards to the ME Regional Lead, that's still a post, and I'll check with Richard in regards to this as well. That is still a post that's out for recruitment, but hasn't been successful in actually appointing, as far as I'm aware. In regards to 2019,
I think the Permanent Secretary is looking in there maybe on that.
Okay.
Go ahead.
No, sorry, I was just saying, Minister, that's my understanding too at this stage, the position you've set out there.
Okay, and Richard, if I could ask, if you do want in on a particular issue, put your hand up on the screen there, because we're not seeing you, obviously, to take an indication otherwise. Go ahead again, Robin. Go ahead. Thank you.
Okay, thanks, Chair. In regards to the update of stroke services, there has been a number of developments that has come out of the stroke consultation in regards to thrombolectomy and the ability to deliver that across a number of sites, 7 days a week, whereas we currently were only at 5. So there has been, in regards to the number of sites where the high dependency units, there is a piece of work actually being going on within the department in regards to that, because of the numbers that we're actually looking at, and where we were looking at population growth and ageing population. I had received an indication that those weren't in keeping with where we were actually seeing both population numbers but also the ageing population in Northern Ireland. So on that specific piece of work, there is more work being done. In regards to the cancer strategy and the rapid diagnosis centres, at this minute in time they are open for direct referral for suspected cancers. But the intention would be, if we can roll out, again subject to funding and staffing, if we can actually roll out more rapid diagnosis centres, the scope of what they can do and also what they can deliver can be ramped up as well. In regards to officials coming in front of the committee, I'm not aware, Paula, what's if they're not coming or not today. I know I did have a meeting with the NIO in regards to this yesterday, and they were expecting to make an announcement today. So unless that has had an impact into that briefing, I'm afraid I don't have an update on that.
Okay, no, thank you. And I'm aware the Secretary of State's due probably even now making the statement in the House of Commons, and I very much welcome that. But I think it's really lamentable that we couldn't get our act together here in Northern Ireland for the women here in Northern Ireland. So we'll wait and see the full wording of the Secretary of State's statement today. But the question I'd asked in relation to stroke services was, would you publish the consultation documents from 2019? I think that there is a call within the sector for those documents to actually be published. So there's transparency around the process. And then
okay, Richard, are you aware, sorry, of where that sits?
No, I mean, as you've articulated, I mean, you clearly, there's some big decisions there for you at ministerial level, and you were rightly saying that the data and evidence position had moved along a bit. So I think it would need to be careful too that we didn't look back and publish something that was out of date now in terms of we're currently go through and refreshing the data and the population aspects to that. But we can certainly take it away, Minister, and look at it in terms of, ensuring we publish something that would be up to date and not potentially misleading in any way.
That would be great. Thank you, and thank you both for your contributions.
Thank you, Paula. I'm going across then to Alan.
Thank you, Mr. Chairman. Minister, you've been able to deliver many worthy pieces of legislation during the past 2 years, and you've also been able to bring forward plans and strategies to address the shortcomings in our health and social care system that have been caused by a decade of underfunding. You've also established inquiries into situations that had been causing huge public concern. How has dealing with the COVID pandemic curtailed the work of your department in delivering the changes you've been seeking to achieve? And just how damaging and frustrating is the absence of a multi-year budget?
Thanks, Alan. And I suppose in regards to your first point as to what we've actually been able to deliver over the past 2 years, I want to pay again my thanks to the committee for being able to do that as well in collaboration from the legislation that we've brought forward. You know, the Health and Social Care Board was announced, the initial closure was actually announced in 2016. We were able to bring that through in regards to the children's and adoption legislation. Again, as has been mentioned in debates, initially started under my party predecessor who held this post, Michael McGimsey. So a long time in the development as well. I think it's 16 years. The organ donation bill that we were able to bring through as well. You know, all done within that two-year mandate that we've actually been able to deliver those services on. But again, Alan, in regards to the other changes that we've made as well, some of it through regulations that I know that the committee members have also been keen in regards to smoking in cars, management of how we produce or how we actually sell vaping products as well. So, you know, an awful lot of work has been done, has been ongoing in the past. Would I have liked to have been able to do more? Yeah. Could we have done more? Without the pandemic or an absence of a pandemic, I do believe so, because I think our elective care strategy, our mental health strategy, now our cancer strategy, you know, all laid out there as to where we see health service in Northern Ireland actually been needed to be delivered and taken. But one thing I will say, Alan, as well, to this meeting, and I know that the committee has acknowledged them as well, all of this, or none of this would have happened without the dedication and delivery of Department of Health staff. Because while many of them across, you know, and that's in here, Health and Social Care Board, Public Health Agency, our arm's length bodies and our trusts, who made all these things happen as well as dealing with the global pandemic as well. So the delivery level, I think, should not go underestimated or applauded as well in regards to what has been achieved. The biggest frustration, again, was in your closing comments about the disappointment and frustration, and I've articulated, and it's not in any way intended to be party political. It's the fact that of all those strategies that we've been able to publish, one of the things I've always ensured, and again, department officials have always delivered on it as well, is that funding proposal, a costed funding proposal, sits alongside each of those strategies, so that people would see not just a strategy, but also what they would get for their money as well if they were putting the investment into elective care, into mental health, into our cancer strategies as well. So that took a piece of work, but we're back now for potentially what is a one-year budget, and that does not allow the Department of Health, it doesn't allow our trusts actually to look long-term, even 3 years into the future, so that they can get a lot of those strategies moved from being pilots or prototypes and actually embedded, where we can actually start delivering them on a sustained embedded process across our health service, which would actually allow some of that change and transformation that everybody wants to see actually happen on a day-to-day basis and actually be embedded.
Thank you, Minister, for that. And Minister, I mean, many times, many occasions during the last 2 years, we've all placed on record our appreciation of our health service staff, and I suppose it's the last opportunity for me publicly to place that on record once again. Appreciation to you, Minister, to your officials, and to everybody working in the health and social care system for their efforts over the last 2 years. And indeed, there are probably many members working away behind the scenes that maybe feel their efforts are not seen, but they are obviously part of a team, and they are appreciated. Thank you, Minister.
Thank you, Alan. And going then on the video link to Carol. Go ahead, Carol. Lanare, Lish, Decashtian, Littlehull.
Apologies for being late. I have no Wi-Fi, so I'm on 4G at the minute. Listen, first of all, I want to thank you all for the questions that have been answered. I've been taking loads of notes. But Minister, I want to try to focus on the growing concern among staff, particularly in emergency departments, around safe staffing. So, for example, the ambulance service normally would have had one or two. Sorry, there's me, but there's a lot of Owen.
Carol, your sound is quite poor. You might need maybe try coming off video, and we maybe can hear you better.
Okay, I've done that. My question to the ambulance staff, I mean, because at the minute there are two calls on a 12 shift, given the backlog of EDs, and there is real concern. They're massively understaffed, as are the emergency departments. I mean, I've had discussions within the Belfast Trust. I've spoken to some very, very distressed staff who've had to deal with very distressing situations. That's one. So it's in relation to the additional resources, the safe staff legislation, and then my last two questions are in relation to, you did mention systems and not structures in relation to Bengal. How can we maintain these systems in this current situation without additional investment, certainly in relation to retention and recruitment of staff?
Thank you, Carol. Yep, go ahead, Minister.
Thanks, Carl. I was getting feedback there, Chair, but I think I picked up the majority of what Carl was talking about in regards to recruitment and tension of staff. A number of specific work streams looking at that, especially across our nursing, actually, piece of work being co-chaired by RCN and our Director of Workforce within the department here as well. But again, it goes back, and I don't want to keep repeating it, but it goes back to the surety of a 3-year budget that allows us to do that investment in staff, it allows us to do that investment in recruiting, which actually is seen as game-changing across our health service, because they have been managing on the receiving end of 1-year non-recurrent budgets for the past 7 years, which has seen them, I suppose, making all those changes that they've had to make, but without the long-term surety that it's actually going to be bedded in. In regards to safe staffing legislation, that team has been established, and it has started to progress some of that work, because it was a commitment again under new decade, new approach, and that will be in place for the next minister whenever they come into post, and we'll make sure that that is delivered, because it's a commitment that I've made, it's a commitment the executive made, and it's a commitment that my department's following up on. In regards to the pressures in our urgent and emergency care, again, you'll be aware of the update that I've got, or our review in regards to our emergency care services, as to what that consultation is actually out at the minute. One of the things that I've also looked is a get it right first time assessment to be undertaken as well, which not just looks at the pressures of our urgent and emergency care, but looks at bed capacity through the system as well. Because as you know, Carl, as you have engaged with those people working in our emergency departments, it's the flow through, it's the getting patients out of the emergency department that actually allows them to get patients out of our ambulances and back in through the hospital service as well. So it's about a whole system approach, just not being able to fix one small bit without the knock-on effect as well. So A lot of work to be done, but there is no quick fix to any of this. But all the building blocks are there, and they're all coming into place. It's just about having, again, the surety of budget and the long-term ability to make those changes that we need to do.
Chair, can I just come back to a small point?
Go ahead, Carol, yeah.
Thank you, Minister, for that. In relation to the ambulance service, have you any update? Because the situation seems to be getting progressively worse. I know some of my colleagues are from rural communities, and it's probably worse there. But if patients are sitting in an ambulance, anything up to 2 hours, that's not safe. So is there any update on that, please?
Well, and again, Carl, so some of the changes we've actually made over the past 2 years in regards to ambulance smoothing, where they go to the emergency department that has the ability to take, and if we see one ED under pressure, they can start to divert elsewhere. Also, the establishment of NIAS halos, whereas there's a NIAS or an ambulance service coordinator actually embedded within emergency departments or some of the emergency departments to be able to see where and how they can manage that flow out of ambulances actually into the service as well. But there's ongoing work in regards to how we manage the quicker turnaround of our ambulances as well. Conscious again, Chair, maybe Richard would want to come in on this point.
Thanks, Minister. It's just to add to the point you've made, there's also the issue just about the staffing of NIAS, and unfortunately, again, all roads come back to the budget position, but there is ongoing work. Recently, as opposed to the in-house training for new paramedics, that's something we want to not only continue but expand. I think we have two aspirations. The first stage is to put enough trainees through so that we can have a safe and sustainable number of paramedics throughout NIAS to allow them to achieve the targets they've set. I think beyond that, there's a real opportunity to think about the deployment of paramedics across the system. And I know certainly some GP practices have looked at the deployment of that paramedic skill set as a hugely valuable skill set, not just within an ambulance setting, but in the wider health and social care setting. So that's more a medium to longer term aspiration. The first programme of work is to maintain and increase the investment in terms of the number of trainees we produced. As you have said, Carol, just the essential needs stay.
Okay. Yep. Okay, Carol, we lost a piece of that, Richard, but I think we got the most of it there. We lost a bit at the very early start of it, but I think we got the sense of it. Okay, Carol, is that you? Yep. Okay, yep. Jerry. Yes, thanks, Carol. I'm going out to Jerry. Go ahead,
thanks,
Jerry.
Chair. Thanks, Minister and Permanent Secretary. Minister, I've raised the issue of NHS pay, obviously, with you several times. And obviously, I think the best case scenario of the pay offer that you and your executive colleagues, or former colleagues, are supporting is 4.1%. There's predictions just yesterday that inflation is going to run at somewhere over 8%. So another real terms pay cut for workers. So I want to ask, in light of the cost of living crisis, of prices going through the roof, has there been any further work by you, by your department, by your officials to press for an increased pay offer for all our healthcare workers, including the department health workers who you thanked there just a few moments ago?
Jerry, in regards to department health workers, they come under the Northern Ireland Civil Service, which is the pay remit of the Department of Finance. In regards to the 4.1%, I'm not sure where you've got that figure from. We did give the 3%, but then I additionally secured, I think it was an additional 25 million, where we went out with actually increased one-off offers, where I had the budget availability to do that within this year as well. So we would hope to see that coming into pay packets, hopefully next month, in regards to where that went across the entirety of our HSC staff. In regards to deliberations, again, you'll be aware of the national, the UK-wide negotiating panel that is there, that comes forward with the recommendation for the increases that are available across. And as you're also aware, in regards to the issue of parity that was agreed previously between workforce, TUS side, the department through new decade, new approach as well. So I'm not in a position to make any statement prior to seeing the recommendation that comes forward from the independent pay review panel. I've had ongoing engagements with our trade union side here in Northern Ireland, and I think it would have been welcomed if they were coming forward as a joint position in regards to how that negotiation is actually taken at a UK-wide level. Because again, you'll be aware of budget insecurities over here, and one thing that our trade union side in Northern Ireland, and I fully agree with them, is that should there be a substantive pay increase across our health service on the workers contained in it, it should be on a UK-wide basis, and that should be funded from Treasury, not from me having to seek further resources simply within the Department of Health budget, which is already overstretched.
Okay, Minister, and I'm sure, thanks for your answer, but I'm sure many healthcare workers will be disappointed by that answer, respectively. I think we should be seeing robust action to say these workers kept people alive during COVID. They've done their bit. We all thank them, but they're being told to wait again for pay fairness, which is really disappointing, and any action they take around that, I'll support them fully. Another question, Minister. I've been contacted, I'm sure other members may have been, by former patients of Dr. Watt. They're concerned that there may be a long-drawn legal process to kind of effectively prove, for want of a better phrase, the harm and the damage that was caused or may have been caused to them. So obviously there will be processes that have to go through, but what assurances can you give as Minister for the next number of weeks, and potentially a caretaker Minister if you are, that there will be no long drawn out processes for those former patients and they won't be re-traumatised again?
Jerry, I'll give the commitment from this department. It's actually a group that the PermSec leads up on in regards to the outworkings of the neurology inquiry and the stance that comes from that. We've never been part of any long drawn out legal process. We've always been supportive when and where we can in regards to, I think it was the comment that Alan made, it was, and that's why I moved the neurology inquiry to one under a public inquiry, so it had the ability to draw all the legal powers that a public inquiry can. Richard, is there anything you can provide in way of update?
Yeah, thanks, Minister. It's the position we're going for is what we call an accelerated scheme. So the Minister agreed some time ago we put additional resources into what's called DLS, which is the Health Service Legal Services, and that's particularly to try and increase the speed of engagement with anyone bringing claims forward. One of the measures is, rather than get into, as has been the case in the past, where each side gets their own medical expert, often gets diverse medical opinions, and then there's a long protracted argument. It's seeking, if we can agree at an early stage, just to go for one joint independent appointment of an independent medical opinion in terms of the harm assessment, just to get that done and move this forward. So there's a lot of energy. Unfortunately, the early stage of the work, there's a lot of preparatory elements need to be put in place. We hope as we start to move forward in the coming months, we'll see more of those claims being resolved and settled and move forward. But it absolutely remains our desire not to put people that have already been through a very difficult process through any more challenging times, and get to an end of this as soon as we possibly can.
Okay, thanks. I'll pass it on to former patients. And finally, Minister, we've heard reports of NHS dentistry at its knees, possibly going to the wall over a number of future years. First of all, what message would you send to patients, and what specifically has been done and will be done to enhance and develop NHS dentistry?
Thanks, Jerry. In regards, we've actually just put in a rebuilding fund into dentistry in regards to where we had been supporting dentistry to make sure the practices didn't go to the wall or go to their knees, as you described. Our Chief Dental Officer has been working with BDA to make sure we can get as many people back and being seen by NHS dentists as possible. We're still working through an assessment in regards where we're seeing those with urgent need first, but we are seeing, I suppose, a disparity across some practices where they have capacity to start their routine checkups again, where some haven't been able to do that. So there's been additional monies put into BDA and that rebuild service as well to get them back up and running.
Okay, we share the information with the committee. Don't know if we'll get to see it before we end, but yeah, thanks.
Okay.
Well, Jerry, thank you.
Thank you. And just in relation to that, and following on from Jerry's questions there, there's a number of strands ongoing and outstanding. I'd like to pick up on with both either yourself, Minister, or the Permanent Secretary. First of all, I am disappointed that the maximalisation process in relation to the public inquiry is taking so long, and I know you haven't received that report yet. But when you do receive that report, and given that maximalisation will have been completed, can you commit, Minister, that you will publish it?
It does become as a public inquiry, Chair. So it's a public inquiry report that comes out. I have no problem at that stage publishing it once I or the Minister who receives it has had the opportunity to read it as well. The maximalisation process that I indicated the last time I was here, an early indication or initial indication is it should be completed by May. So the publication of the report should follow soon after.
Okay, thank you. Another strand then, important strand, is the review of deceased patients that RQIA were undertaking. When will that report be published, or do you have the findings of that report on your desk now?
I don't have it on my desk now. Richard, do you have an update as to when, in regards to timeline?
I think the review of deceased patients, there was 2 phases to it. Phase 1 was the preparatory element of scoping. That's completed. Phase 2, I think from memory, is RQI are hoping to conclude that around about the end of April, May time. Is their anticipated timeline on that? But I know work is progressing on it and RQI remain focused on it.
And are there any early indications of what the impact of that is telling us, Richard?
Well, Chair, until the work's concluded, they'll not be able to draw any conclusions from that at this stage. So they certainly haven't given, RQI haven't given us at this stage a sense of what that's saying, and I suspect they'll need to complete the evidence base before they turn to conclusions. Okay, and then the other one then was the recall. Is there any updates in relation to the recall element of the work that was undergone on neurology? An outcomes report. There was due to be an outcomes report, I think, Richard, before the end of March in terms of the recall. Yeah, that's the cohort 3, Chair. I think that work again. We're at the stage. Obviously, the recall has completed. Again, it's the stage of just pulling the data together and getting a report to the Minister that he can consider. Unfortunately, in terms of timing, obviously, we're about to enter the pre-election period. Obviously, with the Assembly rising too, this is a matter that I think the Minister's indicated he want to give due respect to the Assembly and bring it to them. But it's just an issue of logistics and trying to pull that together. But I think we're very nearly at that stage. Yeah, I'm not clear why that would be delayed as such as a result of it. Surely that is something that would be within the department's remit to produce that evidence and that transparency as soon as possible. What's your view on that, Minister? I think, sorry, Minister. No, the point I was making, I don't want to say, sorry, there's something sitting stewing in the Minister's desk. There's an issue about pulling this together in the first instance. There's then the issue that we just need to take a view on in terms of the interaction with the pre-election period. As you're aware, Chair, there are some restrictions on what the Minister is able to do in the pre-election period, notwithstanding his obvious desire for transparency. Sorry, Minister, I interrupted you there. Okay.
No, I was going to ask you to answer it, Richard, so that worked well.
Okay, listen, a couple of other things that I want to just quickly touch base on with you, Minister, in relation to... Okay, specifically in relation to the GPs, a number of us have done a number of meetings with GPs over the past period of time. I've also met with some of the Health and Social Care Board staff as were in relation to GPs. There's a couple of specific things that are emerging as serious impediments in some cases to potential recruitment of GPs that could ease the pressures. First of all, there's the issue of indemnity around. And uniquely here, I think GPs going into practice here have to pay very high levels of indemnity, £10,000 to £15,000 per year is the figure quoted, before they see anyone. That doesn't exist in other areas. Is that something you're aware of and something you could deal with in terms of trying to improve recruitment from other areas?
Richard? It's not something that's on my desk, Chair, but...
Chair, I'm certainly aware there's an issue about indemnity for those GPs who want to take additional sessions through their divorce service. I wasn't aware, it certainly hasn't been on my desk, about an indemnity issue for the generality of GP services. But I'm happy to take that away, Chair, and have a look at it.
But please do, yeah, and please do take a look at that, because I'm led to believe that it could make a significant difference. Another issue, again, which may be similar, and you can advise me as such. Apparently there's an additional exam here that people coming from the 26 counties potentially have to do, which is also a barrier. It doesn't, I think, apply anywhere else, and it could be extremely relevant, including along many of those border areas where GP services are under particular pressure. Is that something you're aware of, Richard, and something that could be addressed in the short term?
Again, Chair, apologies. It's not an issue I'm aware of. I suspect if it does exist, it's probably more on the professional requirements side as an issue the department puts in place, but happy to take it away and have a look at it, Chair.
Okay, and the third one in relation to that is the visas, the 3-year visas for trainees. So effectively people are coming here on a 3-year visa, being trained as part of the system, then their visa expires and they're essentially forced to either reapply or return home. Is that an issue that could be addressed to try to retain some of those high quality staff in the system here rather than additional barriers?
Again, it's an issue that the best we could do is make representations on, because obviously the issue of visas and that sort of cross-border issue isn't a devolved matter, but certainly it's one that we can continue to make representations on.
Okay, well, I would appreciate if there could be a look taken, because I'm led to believe that those in combination could free up what would be key and very valued staff. The other thing is, I just want to say as a comment, is in relation to the safe staffing legislation. I think that's crucial coming into any next period of time. Richard, before we wrap up, I just want to acknowledge the fact that you are leaving the department, and you've been the permanent secretary of the department through a very challenging time, it has to be said. A time that has seen many health delivery pressures, it has seen the pressures of the pandemic, and we have also seen a number of scandals emerging, including urology, Dunmurray, Muckamore, urology, radiology, and those have all provided their own challenge. Just as a comment, first of all, I want to say I think we do need to see the addressing of the issue of transparency right across the system and the ability of people to gain access to their own information. In many cases, I'm dealing constantly with people who are individually struggling to try to get notes of their relatives, maybe who have deceased or whatever. The system is very hard to navigate in terms of complaints and data and all of that, and I would ask that is looked into in general, and I'm aware that the duty of candour consultation has been out there. But in more general terms, Richard, throughout your period of time in the department, what do you see as having been, significant achievements, and what would your greatest regret be in terms of your period of time in the department?
Thanks, Chair. Firstly, just on your point in transparency, just to say, I think we would absolutely stand shoulder to shoulder with you on that point about the need for greater transparency, and ultimately, data that is held about patients is patients' data, and it should be accessible to them, and that's a position we need to work through. As you say, Chair, I've been here quite a while. I've become 8 years in July. Many challenges. I think the greatest achievement of the service is, as you say, the many difficulties that have been thrown. It's the resilience that has been shown by individuals at all levels, at all professional disciplines, the service. They've stood strong in the face of a huge amount of adversity. They've continued to prioritise the population they serve. And despite the many challenges, and the nature of sessions like this are, we do need to focus on the challenges rather than the success stories, but there have been many success stories. Every single day, many very successful transactions take place across a diverse range of health and social care settings. All too often, we don't stop to acknowledge that. That has been delivered by people who take great pride in what they do. And I think, ultimately, any success is theirs, Chair. They are a spectacular workforce. As a society, we owe them a great debt. And from my perspective, it's been an absolute honour and a privilege to serve alongside them for this period of time. And I wish them, this minister and any incoming minister and an incoming committee, every success in moving forward. But I know we all share the same ambition. And Chair, if I could just very briefly say thank you to you and committee members. That the Health Committee undertakes a hugely important role, that challenge and scrutiny role. I think the service is better for the work you do, and thanks to you and all members for the help you've given. Also, we had 3 years without a functioning assembly. I'm conscious that at that time the Department of Health worked with the health representatives of the individual parties, so it wasn't a formal health structure. But certainly I felt that help and support at a political level was there for me on a practical level throughout that difficult period. So just to log that note of thanks, Chair, if I may.
Yeah, and in terms of an incoming permanent secretary, or in terms of things you would have liked to have seen progressed further, what would your key piece be that you think needs addressed now going forward?
Agenda, Chair. COVID has effectively forced us to. I was going to say stand still. That would be unfair because the system still managed to take some transformation work forward, led by the minister in the last couple of years. But I think we would all love to have made more progress in the transformation agenda, simply because that means we would have a more resilient, sustainable service that's providing better outcomes. So I think that obviously, as the minister has indicated, is a very significant priority for the coming months.
Okay, thank you, Richard. And yeah, and I do want to acknowledge the role that you played during that period of time, and I do recall that the extensive work that went on, kind of almost as many of those other issues were swirling around, and that issue of the still undelivered transformation, which could bring so much improvement and opportunity into the system and remove pressures. So I want to wish you well in terms of your new role, Richard, and to thank you just in terms of your role in the Department of Health. Minister, I also want to wish you very well in the period ahead, and obviously we're heading into a very uncertain time in some ways, and I think as a Health Committee we certainly understand and would have certainly a desire to see things back in place as quickly as possible. There's so much work to be done in terms of health. There's so much to be done in terms of transformation. There's so much to be done in terms of supporting our frontline staff and improving the delivery of services, including those vital waiting lists that we all know are in such need of a focus and attention. But I do want to thank you, Minister, for your engagement with the committee. I think that has been, a regular engagement, and I want to acknowledge that. I think that's been a useful element of the period of time and allowed us to do substantial work, which was often done in a very positive and constructive fashion from, I think, the committee and yourself and your staff as well, your officials who attended committee over a period of time, who took questions, who took issues away, who made changes, and some of the key changes that I was delighted we achieved was on behalf of young people around COVID and those ensuring that those inspections for young people and the issues around mental health and people who are detained with mental health were addressed quickly, and I do welcome that. I also want to, just before bringing you in for a few closing words yourself, Minister, I want to, via yourself and on behalf of the committee, thank each and every one of your staff out there. I include department staff, I include staff within the leadership of the Trust, and all those frontline staff who are working so hard every day to plug gaps, to provide services in challenging situations, and they continually rise to the demand. It has and it is taking its toll, there's no question about that, and we need to urgently address the retention, recruitment and the support of staff. And that's an onus and a responsibility on us all that I think, and certainly an imperative to us all getting back and to seeing a new executive in place, a new committee in place, and to continuing that work on stabilising the situation for staff and on behalf of the population. But thanks to you for that. And then I'll just give yourself a few words, Minister, if you want, in closing.
No, Chair, and again, I think I was trying to get a rough count. I think this is either my 22nd or 23rd appearance in front of the committee, and I've always found them to be beneficial in one way as a challenge function, but also that supportive function, not, as I said, not just to me or department officials, but to the wider message that went out to our health and social care staff. And just want to reiterate your closing comments there, Chair, in regards to that. Thanks. I think, and this isn't platitudes for platitudes' sake, Chair, I think the relationship that has been over the past 2 years between yourselves as a health committee, your committee officials, the department officials, trusts, all our arm's length bodies and everyone who is engaged via the health committee in regards to better informing, better challenging and better instructing what my department has been able to do over the past 2 years, I think is actually, and we've both said this, Chair, in the chamber, it has been an example of how our devolved institutions should work. And I think we have been able to show that constructive engagement that can be had across party politics, across ideology, when we as elected representatives working within the functions, within the structures that we have, engaging with stakeholders, engaging with the general public and engaging with those who deliver services can actually bring about a better change and a better delivery for the people of Northern Ireland that we want to take part of. So Chair, I thank you for your words, I thank you for your support and across all the members of the committee, and I thank them for their challenge as well. Because without that function and that challenge function that a health committee provides and has provided, some of the changes that you have referenced wouldn't have been made. They wouldn't have been highlighted, because that's the relationship that both we in the department, me as Minister and you as a committee, have, and it has been productive, it has been positive and it has been constructive. Sometimes I've found it personally challenging to respond to some of the comments in regards to how it was delivered, but in regards to the work of your members, Chair, because I know how much time it has taken up going through not just the COVID regulations, as I said at the start, but a number of very detailed pieces of legislation coming from my department, but also a number of very detailed and sensitive private members' bills that you and the committee have also managed as well. So, Chair, in regards to that, I think we've probably enough 2 to 3 engagements now in the chamber today in regards to those pieces of legislation coming forward, but just in regards to the function and the engagement that we've had through the committee structure, I want to thank you, your staff and the committee members for that constructive, positive engagement that we've had over the past 2 years.
Okay, thanks, Minister. I just want to take Deputy Chair Pam Cameron in for a few words there as well. Pam, go ahead.
Thank you, Chair, for the opportunity of saying something at this point. I just wanted to put on record my thanks to the Minister and to the Permanent Secretary, and wish Richard you all the best in your new role going forward. And I just wanted to also put on record and ask you, Minister, if you would pass on to the trusts and indeed to all the health officials and staff who some of which have been very much behind scenes under incredible pressure, especially in relation to the COVID regs and all of that. It's been a very back to front process all along, which none of us have really enjoyed in any way. But to thank you for your work in this period of time, and I do appreciate that there has been enormous amount of work that's going on in terms of health, and yet we are all still critical of what has not happened. And transformation is a really critical item, which we really needed to see more done on, and that is disappointing that that more couldn't have been done at this time. But I do wish you well personally, Minister, going forward into the elections, and with whatever role that leaves you in after election as well. And again, just to say a huge thank you to all your team behind you. There's obviously a vast amount of people involved in keeping health on the agenda. So just to thank you for that at this time. Thanks, Chair.
Yeah, thanks, Pam. Thanks. And Robin, I also want to just actually acknowledge the work of your private office and yourself in terms of being available to take a phone call or to address issues that did arise at particular times, to the greatest extent possible at times. But I do want to thank all your staff, as Pam did there as well, in terms of their assistance to us. So listen, I want to wish you both all the very best in the time ahead, and I look forward to seeing work continue to the greatest extent possible. Health is one area that there is really no time to delay. There is no time to waste. So I wish you well in this period of time, Minister, in what will be challenging times continuing throughout. But I want to extend my best wishes to you both, and thank you. Gormagat. Okay, members, I'm going to take a short break there before we take the RCN session. So if we could come back at 10:55, please. That's about 10 minutes, is it? Yeah, thank you.
This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland.
Okay, thank you, members. So we're now resuming our Health Committee this morning. First item then, we're going back to item 1 after having heard the briefing from the Minister and the Permanent Secretary. In terms of apologies, Clerk, do we have any?
Yes, Chair, just Colin McGrath has said he probably won't make the meeting this morning.
Okay, thank you. And there's no other, all other members are attending. Moving on, members, then to the draft minutes. There are 4 sets of minutes then to approve at this meeting, members. I refer you first of all to the draft minutes of the meeting of the 8th of March, which are at tab 3.1 of your pack. Are members content with those minutes? Yeah, thank you, members. Refer members to the draft minutes of the meeting of the 10th of March, which are at tab 3.2 of the pack. Are members content with those minutes? Yeah, thank you. I refer members further to the draft meeting minutes of the meeting of the 15th of March at tab 3.3 of the pack. Are members content? Yeah, thank you. And refer members to the draft minutes of the meeting of the 22nd of March at tab 3.4 of the table papers. Are members content with those minutes? Yep. Thank you, members. There are no matters arising from those minutes, members. So we're moving on then now to our second substantive briefing this morning, and this is a briefing from the Royal College of Nursing. I refer members to a briefing paper at tab 6.1 of the pack and to recent correspondence from the RCN in relation to patient safety in emergency departments at tab 6.2. And I know that is something that the committee are extremely concerned about as well. So I think we're looking forward to the briefing this morning, very much so in terms of those concerns and considerations. I'd like to first of all welcome Ms Rita Devlin, who's Director of the RCN here in the North. Rita, can you hear us okay?
I can. Colin, can you hear me?
Yep, I can, Rita, thank you.
Thank you.
We have Ms Fiona Devlin, who's Chair of the RCN Board. Can you hear us okay, Fiona?
I can, Chair, thank you.
And Andrew Doherty, RCN Board Member. Can you hear us okay, Andrew?
I can, Chair, thank you.
Okay, so listen, Rita, I'm delighted you can join us this morning, and really do appreciate your attendance here, as we have on every occasion. And we see the nursing cohort that you represent as absolutely key and one of the most phenomenal workforces I think that we have, and we're very lucky in such challenging times that we have had a workforce who have stepped up time and time again to deliver services. We are acutely aware that the pressures remain. The pressures continue, in fact, in many ways probably to grow. The committee has expressed their concern repeatedly around the issue of safe staffing and the need to have that legislation brought forward, the need to support and retain the current workforce in terms of nursing and all of the other professions, and also the need to urgently and in a very effective and planned way to recruit staff into the delivery of health and social care services and nursing in particular. So we'll go back to yourself, Rita, then, if you want to make some opening remarks, and then we'll come around to members' questions. Thank you.
Thank you, Chair. So once again, the Royal College of Nursing wants to thank the committee for the opportunity to outline some of the current issues facing the nursing workforce in Northern Ireland. And as you say, I'm joined by our Chair, Fiona Devlin, and one of our elected board members, Andrew Doherty. We know time is of the essence, so I'm going to keep these remarks as succinct as possible. We have already sent you the briefing, which focuses on 3 areas of concern for us. The first is the unsustainable pressures in emergency care and the recent escalation of related concerns by the RCN Emergency Nurse Network in Northern Ireland. In line with our professional requirements defined by the Nursing and Midwifery Council Code, the network recently wrote collectively to the Minister, the Permanent Secretary, the Chief Executives and Directors of Nursing of the Trusts, the RQIA, the Health and Safety Executive for Northern Ireland, and, as you know, to all members of the committee. The letter acknowledged that these issues are neither new nor quickly resolved. However, it did point out that the pressures in the system have now escalated beyond the level of being simply unacceptable, to the point where, in the professional judgment of the network members, all frontline staff, the emergency care system is beyond the point of collapse. Accordingly, the letter stated that the safety of patients in the emergency departments across Northern Ireland can no longer be assured. The RCN is aware that the committee have already discussed this letter and we're grateful for your collective undertaking to address the issues raised by our members. Our briefing paper also highlights 2 key issues that the RCN will be highlighting in advance of the forthcoming Assembly elections. In relation to safe staffing, the RCN is focusing on 2 priorities. First, safe staffing legislation must be introduced as early as possible in the next Assembly mandate. The RCN is aware that the Department has recently written to the Committee to outline its legislative programme for the next 5 years, and we are reassured that the legislation is to be prioritised. However, despite the support of the RCN and other unions, we are disappointed at the progress made by the Department over the past 2 years, and we do not believe that it has been given appropriate priority. Our manifesto also emphasises the need for an overarching health and social care workforce plan, something discussed earlier this morning. The RCN has highlighted on many occasions how an absence of proper workforce planning in Northern Ireland over the last decade has underpinned the current crisis. We welcome the attention to this issue by committee members and a number of other MLAs in recent weeks. We are dismayed at the Minister's response, in which he outlines how the intention of the Department of Health is to have the workforce plan in place by 2026. The health and social care system in Northern Ireland is widely acknowledged to be beyond the point of crisis. We cannot wait 4 years to have a proper workforce plan, and we don't accept that the workforce reviews which the Department are leading on are acceptable as a substitute for systematic workforce planning. In the intervening period since our last evidence session, the 3% pay uplift for 2021 has been implemented. Meanwhile, the RCN has submitted written and oral evidence to the NHS pay review body for 2022 to 2023. Our evidence calls for the need for a substantial pay award to address inflationary pressures and provide an initial instalment on redressing the real decline in the value of nurses' pay since 2010. It also places a fair pay award in the context of wider moves to retain nursing staff in Northern Ireland, an issue on which we focused in great detail, if you remember, in October. Finally, we need to address the issue of huge current concern, particularly to community nursing staff. I refer to the recent escalation in fuel costs. The RCN is calling for an urgent and early review of the current mileage rates payable to nursing staff in order to deal with the recent and dramatic price increases in fuel. We are also calling upon employers across the RCN, or across the UK, to provide an immediate additional payment at this time. With the recent increase in prices at the pump, current reimbursement rates are leaving staff significantly out of pocket for just doing their work. The announcement in the Chancellor's Spring Statement yesterday has left nursing staff feeling extremely shortchanged and actually very concerned. The cost of living crisis means that some nurses are having to choose between putting petrol in their cars and feeding their children. When community nursing staff drive great distances to see their patients, giving vital care and trying to keep patients out of hospital, this is not enough action. They need immediate additional payments and an urgent review of the rates. The RCN is aware that Assembly members are receiving many messages from nursing and other health and social care staff who are affected by this issue. We also know that many MLAs have raised the issue with the Minister for Health and the Finance Minister. We thank the committee for highlighting this issue, and we would urge that this continues during the election campaign. As this is the final committee meeting of the current mandate, the RCN would like to thank each member who has served during the past 2 years or so. We have valued the support that the committee has shown for nurses and nursing in Northern Ireland, and we look forward to engaging with the committee once again during the next mandate. Thank you, Chair.
Thank you, Rita, and thank you for those opening remarks. And I have to say they do reflect the committee's concerns around the pressures that continue across a number of fronts. If I may, I'd go back first of all to your letter, and I thank you for sending that letter to members and to wider the department, and for raising these very serious concerns. I am aware that the overcrowding in emergency departments is having an impact both on the downstream and the upstream side of delivery, very worryingly at the present time, around the issue of discharge for ambulance staff and returning those staff back out onto the road, and indeed the impact of patients awaiting either transfer into the department, awaiting a bed when they arrive in the emergency department and need admission. And all of those issues are just impacting across the system and impacting on your staff hugely, in terms of, staff who have joined a service to provide care, but who are being challenged by, people, waiting rooms sitting with 70, 80, 90 people, with sometimes not even places to sit. And that has to be absolutely soul destroying, I think, for staff who come into a profession to provide care, to be working in those circumstances. And I think there's an onus on us all to address those issues urgently. Could you give us an example of how that's impacting your staff? Those overcrowding issues in EDs and other services are impacting on your staff in the first instance. Rita, please.
I think, Colin, when you use the word soul destroying, I think that basically sums it up. We had a meeting of our emergency care network nurses, it was about 2 weeks ago now, I think, and it was heartbreaking to hear. And I know a lot of these nurses, and I know them very well, and they are excellent nurses. They're people that you would want to care for you if you were ill, and it was heartbreaking to hear the stories of how they feel they have absolutely, totally burnt out, and that they've nothing more to give. And, even the thought, people said they feel sick before they come to work because they know what they're coming into. The idea that you walk past the same patient maybe 100 times in a shift, maybe a vulnerable older person in a bed, or even worse, in a chair, sitting waiting to be admitted to hospital, and you're walking past them maybe 100 times and not able to care for them the way they need cared for. And what that does to professionals who come in, as you say, Chair, to do the very best they can for patients. I don't think I have enough words to describe the despair that we heard that night from our members. But also, one of them likened it to somebody handing you a bomb, and people putting handing the bomb around and waiting to see who it was going to go off on, because they are very concerned about making a mistake. They're very concerned about doing something that would harm a patient. And I know that it has been said, during the pandemic, these things will be taken into account if something happens. But those nurses would still be investigated, would still be up in front of the NMC, would still have to undergo a full investigation. And apart from that, if you felt that by either an action or omission that you had harmed a patient, that lives with you for the rest of your life. That isn't something that goes away. So I don't think I'm putting it too strongly here when I say they are absolutely distraught and frightened and afraid, and they see no light at the end of the tunnel. There doesn't seem to be anything happening that is going to change the current situation.
Okay, thank you, and that's hugely concerning, I have to say. And the other element of that then, Rita, if you could, and I know that you have identified this and highlighted this in terms of the undermining of patient safety and dignity as a consequence of these factors. So could you give us some idea of the impact on patients and that issue of safety that you highlight there? Please, could you draw that out for us?
I think patient safety, nursing is a safety critical profession, and you need enough nurses to be able to ensure that you can keep patients safe. So when patients are ill, there are things you need to do. You need to do regular observations. You need to, because you're looking for deterioration or any changes. If you have maybe 3 medical wards full of patients, plus then the emergency patients coming in, it stands to reason you can't do those things. And what you're doing is you're not able to do the things that you should be doing to look after patients. There is no privacy. There is no dignity for patients. Patients who need to use toilet, it's just unthinkable. We wouldn't put up with it ourselves. It is unthinkable, some of the things that are happening to some of our very elderly and vulnerable patients in the ED departments. And I don't think I'm being too strong in my descriptions here. I think it is unacceptable the way that our patients are being treated at the minute. And elderly patients lying in the back of ambulances for 8 hours, waiting to get into the ED to maybe get a chair, if they're lucky. It's unthinkable that we have now come to a situation where that's the norm. Yep. It's unthinkable.
Yeah, thank you. And listen, I know that we have raised these issues in the previous session with the Minister. I think it is fair to say there would be elements of that we're disappointed that there's not more certainty and clarity as to what is being done currently. I know it has been expressed, and I have expressed it before, extreme disappointment that there's a stated desire to have the workforce issue addressed by 2026, when we're currently, as you described, beyond the point of collapse in relation to many of our services. So, from your perspective, what would it take at this point in time to make a material difference to how we're going about the workforce planning, recruitment and the implementation of having the workforce available to plug these gaps?
So I think that we need to. I'm not sure where the conversations are having that are looking at that are being had that are looking at the system as a whole. So we have more beds in the independent sector than we have in hospital, and yet the independent sector work seems to sit in a silo away from the rest of the work. We need to see the health service in Northern Ireland as a full system. We need to look at how patients are getting into the ED, so the GP practices, what's happening there, and then how we get patients out earlier, so all the care packages that need to be in place. And we are in severe difficulties in terms of the number of district nurses and community nurses we have to enable patients to come out. So from my point of view, maybe these discussions are being had, but we're not involved in them. And I know that a lot of our frontline nurses aren't involved in them. And we need to have a whole systems approach. We need to look at what Bengoa said. We need to start to actually transform services. We need to make sure that the right people are seen in the right place at the right time by the right people. And that means that we see our service as a whole service. And where care is delivered, we have to make sure that we have the appropriate people to deliver it. One of my concerns that you mentioned earlier, and the Minister mentioned about the multidisciplinary teams working within the GP practices, I would absolutely agree that those are the right places to have those people. But the problem is when they're moving to the GP practices, you're really robbing Peter to pay Paul, because they are leaving big gaps in services somewhere else. So, I've said this before, Chair, we have one workforce pool in Northern Ireland. They're trying to split one pool in 100 different ways, and they're trying to use the same people in different places, and that just won't work. And again, we're back to the whole idea of a workforce plan that isn't looking at the system as a whole system. And we will never, for example, have a preventative health service when we keep cutting health visitor numbers, when we keep cutting school nursing numbers. Those are the preventative end, and the prevention and the wellness service people. But when we keep cutting them and cutting the numbers, we will never have a service then. We're reduced into an illness service, which is a much more expensive service in the long run. So it's a whole systems approach, and we all need to be in the room together working on that to make sure that we have a system that is fit for the people of Northern Ireland who deserve better than they're getting.
Okay, thank you, and thank you, Rita. Okay, I'm going to move on then to members' questions. So I have Deputy Chair Pam Cameron, then Karen Killen, and then Deborah, and then Paula. So I'll go to yourself, Pam. Lanare Liddahall.
Thank you, Chair, and thank you, Rita, and your team for your attendance at committee today. And I think it's a really powerful presentation that you're giving to us today, and adds to the letter that we received recently as well. But I wanted to thank you for that briefing, and also to thank you for the continued dedication of and professionalism of the members of RCM. in what are really challenging times. And I have to say that we as a party, we completely agree with the vast majority of the points that you've contained in your briefing, and particularly the need to accelerate a fresh workforce strategy. I think that's really, really important. And it has to be said too that nurses and midwives deserve a fair pay award, and absolutely that review of mileage rate needs to happen and happen very quickly. And I would also support you in that call for an immediate payment, given the cost of living crisis that we're in as well. So, and it's also very crucial that nurses who act in their statutory duty to raise concerns around risk to patient safety, particularly in respect of staffing and resources, that needs to be treated seriously and respectfully by trusts and by the department. I would also back you on that. I have a couple of questions for you, Rita. I wanted to ask what data the RCN holds on trends in surgery nurses leaving service, retiring, or being abstracted from theatre roles. That's my first question, and then I have another one for you.
Thanks, Pam. We don't hold that data because we're not given that data. So we can only go on the data that the trusts present publicly, because if we ask those questions, we don't get the answers. But what we do know anecdotally is that we, particularly Musgrave Hospital, for example, Musgrave Park Hospital, we know that they lost a significant number of their orthopaedic nurses, a significant number, a number that would probably render Musgrave Park now not able to deliver on the workload or the waiting lists in the future. Some of that was because they were redeployed. Some of that was because they've left to go and work in agency. And as you know, we have an ageing workforce as well. And people who may have in the past maybe decided to go an extra 2 or 3 years have left because they can't cope with the pressures anymore. So we are, and you know, we have conversations with the Royal College of Surgeons all the time. We are severely worried about our ability to come out of the pandemic and to have a workforce fit to bring us back through transformation to a time where we can actively tackle those waiting lists. So we are extremely worried about that in the future. And, you know, theatre nursing, for example, was always an undervalued role. But you only undervalue nurses until you don't have them. And then you realise the value of them, and then it's too late. Because those really, and I'm only using orthopaedic nurses as an example, those surgical nurses have honed those skills over years and years, and they can't just be replaced tomorrow. And so we continuously are penny wise and pound foolish when it comes to treating nursing staff well. We always seem to see them as a cost instead of an asset. And good nurses and well-trained nurses and enthusiastic, well-motivated nurses are an absolute asset to the people of Northern Ireland, but we continue to see them as a cost.
Thanks for that, Rita, and completely agree with you there. And I suppose, Chair, I should declare an interest as having a family member who is a nurse and has worked in theatre. So I know the incredible work that they do, and you're absolutely right that those talents cannot be replaced overnight, and we have to be aware that nurses too have health and mental health needs, and they need to be addressed as well. My other question to you, Rita, your briefing mentions clause 16 of the Nursing and Midwifery Council Code. What reciprocal duty is there on employers and trusts to respond to the concerns raised by nurses about patient safety, and should these requirements be strengthened?
I'm not sure that there is a reciprocal duty, to be honest. I have to say that we have had some responses from the trusts to our letter, and they're still coming in, and they are comprehensive, and we do believe that they are taking the issue seriously. And the trusts are very keen to identify what they're doing to try to improve things. I suppose my question is, why are they not working? Why is what you're doing not working? We in RCN raised the issue of the ED pressures. I think we had a summit back in 2014. My date might be wrong there, but you know, we raised those issues then and we weren't listened to. We've raised the issues now. The trusts, as I said, have come back and are doing the work around what we need to do, or what they are doing. But why is it not working? If all of these people together are telling us all the things they're doing, why are we still in the position we're in today? The other thing I would say is, well, there may not be a reciprocal need for them to respond. In any investigation and in any inquiry that would move forward in the future, those letters from the nurses could be used as a focus for the inquiry, and the response to those letters could be critical in ascertaining how the risks to patient safety were identified and discussed and addressed.
Thank you, Rita.
Thanks,
Chair.
Thank you, Pam. Going then on the video feed to Carol Nichillen, Lanneray. Carol Liddehall.
Gurmyaga Caherley. Rita, you've almost answered some of the questions I'm going to ask, but I want to start with the one that you ended on. First of all, has the Trust given an explanation or an action? Well, probably it's more of an action plan to decide what they intend to do. Because, you know, I've declared an interest. I mean, I have family working in community health as well as formal health and social care, but the issue is that, first of all, there's no data. Secondly, they're being told what needs to happen. They're responding with what they're doing, but it's still not working. So, you know, have there been discussions to hone in on particular actions around safe staff relation? As an example, for example, even within emergency medicine? That's my first question, Rita. If you want to ask that, I'll come back to two more I have.
Okay, Carol, if you don't mind, I'm going to let Andrew. Andrew's one of our staff side secretaries and he's really close to this issue at the minute. So, Andrew, do you want to maybe start and answer some of Carol's question, and then I can come in if...
Yeah, thanks, Rita, and thanks, Carol, for the question. I suppose from, I predominantly work in the Western Trust, and the pressures in ED have, like every other trust area, been really unprecedented over recent times and growing every single day. And the impact you've already heard that that's having on our nursing workforce is huge, both in their emotional well-being and their physical well-being, and then on the patient care. So within the Western Trust, there is an unscheduled care project group, and staff side are welcome to attend that, and I attend regularly. And within that, there are discussions and plans on how to stabilise that workforce, how to try and recruit ED as a place of employment, and then how to retain nurses within ED. And like the previous question from Pam, theatre nurses have a massive skill set, but ED nurses similarly have a massive skill set and are really, really difficult to get to that point. It takes quite a significant period of time and cannot be replaced that easily. So there are groups going on within local trusts, stabilisation groups and projects happening to try and recruit, retain and stabilise that workforce. The difficulty is that the nurses just aren't there to, and the attraction isn't there to come into a crowded ED where you may not get the preceptorship and the mentorship and the development you need as a new registrant in particular. Those opportunities aren't there. So new qualified nurses don't look there as an employer of choice and as a place where they want to work. So those groups are happening. We are trying every method that we can locally to try and keep the nurses that we have, particularly in the ED departments, and to equip them with the skills they need to deal with the patients that are coming through the doors. And I say that is similar across most trust areas, and RCN representatives and all our trade union colleagues are present in those, trying to offer some support and advice to our members and to staff management side to try and to coordinate a concerted effort to make things slightly better.
Thanks, Andrew. And Carol, if I could just say, the Minister, as you know, asked for a retention strategy to happen. There was a survey done, and we've seen some of the indicative results of that survey. And if I was to say that it makes quite grim reading, I don't think I'd be being too dramatic. Within the survey of nurses, there were three things that have come out. The first thing, what the question being what would keep you in the health service in Northern Ireland, the first thing was safe staffing. Having enough nurses to be able to do the job we're trained to do. The second thing was pay, but not just pay as a value for work done, but also career progression and being able to progress your career in Northern Ireland. And the third was flexible working. So those are the things that are coming through, and they echo what our members tell us all the time. So they're not new, and they're not a surprise to us. So the retention strategy group are setting up a group of recommendations, and I would say we must commit to trying to implement those recommendations as soon as possible. Otherwise, we are going to lose more staff, and it doesn't matter how many new people we bring in if we can't keep the ones we've got. It's a leaky bucket, so we just have to make sure that we do. We listen to what the nurses told us, and we do implement those recommendations as quickly as possible.
So, Chair, thank you, Rita and Andrew. So, Chair, Rita outlined how difficult it was for members of staff. There's also now a culture where people working in health and social care, particularly frontline, feel that they're very vulnerable professionally, that they're not getting enough support within their health and social care setting, that between, for example, in the emergency department and the ambulance service, everybody's working flat out. And I described this to the Minister on a previous occasion. It was at one stage the emergency department in Oriel looked like something not of a first world health and social care system. And every other weekend or every other day, we're seeing pleas from different trusts for staff to come back in. So in relation to the safe staff and supporting the nurses and indeed all health and social care workers, including the ambulance staff, has there been any discussion with the trust to have those? And then my last and final question is, I have raised this before in relation to theatre staff. So in relation to the matter, the HPV surgeries, the nurses became intensivists because that's what they're trained to do, and stepped up to a mark like everybody else in relation to intensive care as a result of COVID. But those staff, those nurses, are still not knowing where they're going to be. They're getting shifted around. Their skill sets are diminishing. There's no career pathway, and they feel extremely vulnerable. And they also said if they were in front of a tribunal, they also have to pay for legal fees and things. I mean, that's the grounds that people are talking about and they're worried about. So has there been any discussions even with the ambulance service, your staff, Rita, the people that you represent, and indeed trusts, about limiting the responsibility and the vulnerability of staff in absence of safe staff legislation? Thank you.
Carol, we raised this issue both with the Nurse and Midwifery Council because they have a duty to protect the public, and we raised it we've raised it continuously with the trust directors of nursing, etc. So what happened was that the NMC and the chief nurses within the 4 countries came out with a letter basically to say that due to the pandemic, in the event that maybe a nurse, for example, would get into trouble for having done either the wrong thing, either because they were redeployed to an area they didn't know, or because there wasn't enough of them, that basically that would be taken as mitigation in any subsequent fitness to practice inquiry. That for me is not enough, because that's all very well for them to say, and as the RCN who would be representing those people, we would absolutely be pushing that as a mitigating factor. But I think the committee have to remember, if you caused harm to a patient, that can ruin the rest of your life. Because if you did something that caused significant or catastrophic harm to a patient, you wouldn't be able to live with yourself for that. So it's all very well for these people to say, look, just keep on doing what you're doing and we'll have your back. They don't have your back, because you'll be the person at home on your own, wondering about what you did and how you may have caused harm to somebody else. So I'm sorry for me that's not enough. It's not enough to be putting our nurses in this position day in and day out, and wondering where they're going to make the mistake and who's going to come to harm. So for me, it's not enough. And the responsibility for patient safety and patient care in the system does not rest on the nurses. It rests with the people who run and finance and organise the system. And I'm very clear about that, Carol. And just to reassure, if any of our members do need legal help, that's part of their membership, so they won't have to pay for it. That's part of their membership fees for the RCN, so they will be equipped with legal advice. But I mean, if you get there, we've done something wrong. If our nurses are ending up there, then the system's wrong in the first place.
Thank you, Rita. Going then to Deborah. Go ahead.
Thank you, Rita. I know we've met very recently, and I appreciate your time before the committee today. Just to reiterate some of the things that members have said as well, it's important that the concerns are listened to, but not just listened to, acted upon. And I suppose, our platitudes and what we say and how much we respect nurses should be reflected in the actions as well, across the board. So I do just want to say thank you and totally agree there with members in terms of saying, our nurses and midwives do deserve the Fair Pay Award, and the sooner that we can work towards that and get that in place, the better. Just a couple of questions. You talked there about not being, I suppose, at the table in terms of some of the discussions that we need in terms of fixing some of these workforce issues. So therefore, would you be concerned that the changes that we need in terms of our workforce planning won't actually be dealt with effectively?
I suppose my concerns are that we still continue to see the health service in Northern Ireland as a siloed place of work. So we see urgent and emergency care, we see elective care, we see independent sector. We see them as separate entities, and then our GPs are out somewhere else as a separate entity. It seems to me that we are not looking at the service as a whole service and thinking about where is the best place to care for these patients, and in order to do that, what workforce planning do we need to do? Because some of the workforce plan, if you remember Transforming Your Care, for example, the idea that we would care for more patients in the community, it's absolutely the right thing, but they didn't prime it in terms of, they didn't give us extra district nurses, extra GP capacity, extra physio rehab, etc., etc. So you cannot move your services from one place to another without actually having the services and the people and the skills in place to do it. Just wanting it to happen doesn't make it happen. So workforce planning needs to be the first thing that we think about. If we're going to transform services, for example, for the multidisciplinary team into where they're near the patient at the GP, well, what workforce planning have we done that we don't just move the deck chairs around the Titanic and Rob, for example, I think a classic case, and it's not nursing, but a classic case, we brought pharmacists into GP practice surgeries, and now we can't keep our pharmacies open because there's not enough pharmacists to keep the pharmacies opened. So whilst that's the right idea, the workforce plan needs to be the first place that we go. And then we think about how we move the services. We can't move the services and then workforce be sort of an added thought. I mean, it just doesn't work that way. But I don't know. Certainly we're involved in some discussions around nursing workforce planning. But the workforce planning is not related to the services that we see moving forward to the future. So we need better linked up systems. We need better linked up conversations. We need a better vision for our service for the future. I mean, we're small enough in Northern Ireland, we should be able to do it if we had the will, and we were all pushing forward with the same, with the same idea and the same vision.
Okay, thank you for that. And in terms of them, maybe following on from that a wee bit, what other specialisms need to be prioritised in future workforce planning?
I'm going to bring Fiona in here as the board chair, because Fiona's background is in community nursing, and Fiona could maybe answer some of that question for you, please, Fiona.
Thanks, Rita. I think, in relation to workforce planning, as Rita has quite rightly pointed out, to have a proper workforce to meet the needs, and especially she referred to TYC or transforming your care, the whole ethos was about moving the care into the community, but with that, the infrastructure, the resources weren't put in place. And we know that with workforce planning, to be fit to facilitate that care in the community, we needed to have the right number of district nurses, health visitors, social school nurses, community mental health, learning disability. That did not take place yet. We know that there's been an increase in demand in the community with the quicker discharges without the backup of package of care and the social care package that is wrapped around that to facilitate it. And we know that there's poor access to the hospital services, so everything falls back on the community, and the workforce in the community is just it's at a point now where it can't cope any longer. We know that for example our district nurses or our community staff are actually doing the work of the social care staff. For example, packages of care, as I said, aren't there. So as a result, there's no workforce there to provide it. We know that there's long waiting lists for people to get packages of care. So there's a backlog because that goes back in and stops the discharges taking place. But our district nurses now are having to help families wash dying patients. That, which is something that, social care is supporting the district services. We know that because of the increased need to support the nursing homes and residential homes, that's adding extra workload onto the district caseloads. It's already spiralling out of control at the moment. The district nurses, for example, are still doing calls, visiting patients where the GPs and out-of-hours should be doing. And they're having to take photos and actually make medical decisions in the absence of GP visits and that. So there's been a huge pressure, school nurses, and especially through the pandemic, there was increased pressure put on them and not the workforce to supplement or support them. And we're now worried, both school nurses and the district nurses, that if a fourth vaccine programme is rolled out, who does that? Where's the money going to come from? It'll just be rolled in as part of the overall workload of district nurses. But we're at a stage too where we know, especially in Northern Ireland, the ageing workforce, especially of the community workforce, is quite high, and we know that we are losing. Andrew and Rita referred earlier to the expertise of the surgical and the ED. You have to do a specialist qualification to become a district nurse. And the skills and expertise that they have is surmount to none. But the thing is, they're actually doing other people's roles as well as their own, because there aren't those other professions there as well. So it's insurmountable, the amount of workload, the pressure on them, the increased complex cases that's now been discharged out, and the resources infrastructure isn't in the community, let alone the workforce. And we know that, and I said it in October when we were given evidence, we're working at a huge deficit, maybe 89% of staff off in a locality, and yet still meant to give safe and effective care to patients. You can't do that. And if that was on the acute side, the ward would be closed down if there was that amount of staff absent. So there's huge issues, huge pressures going on in the community. And can I just say that the letter that the emergency department staff put in, that letter could have been signed by any of our members, whether it's a surgical, medical or community area. That letter covers it. And Rita said earlier in her opening remarks about, staff talking about passing around a bomb. The language that was used in that meeting was, I have to say, in over 36 years of nursing, was horrifying at this stage when we're supposed to be progressing. To talk in terms of warfare and relating that to the nursing situation, but that is the same in every area and specialism of nursing. To say that they feel that they're no longer conditioned, and they're not conditioned for a level of poor care, and that neglect, and this isn't just an ED, neglect in all of the healthcare service areas is being normalised because there is not enough staff to try and provide the safe care. Compassion fatigue everywhere. So there's a lack of workforce planning for those specialisms, as I've outlined, and the pressure that those areas are under is the same as in the acute side. And that letter could have been signed by any one of our members anywhere.
Okay,
thanks, Fiona.
Okay, thanks, Deborah. Paula?
Thank you, Chair. And most of the questions I was going to ask have been asked, so I just want to thank you for your information this morning and your briefing. I suppose one area I don't think has been touched upon, and that's the experiences of nursing students on placement. I've been contacted by some young women who've just joined the QUB nursing course, and they've indicated that amongst the cohort, they'll be in small cohorts because of the pandemic, they're receiving quite different experiences in terms of their work placement and the sort of skills and the knowledge that they're building up. And I'm just wondering, to what degree do you think that, first of all, are you hearing that as well? But also, to what degree do you think that the pressures that the actual nursing staff and the new registrants, etc., are under is actually having an impact then on the experiences of the student nurses that are coming through? Thank you.
Thanks, Paula. I think we're in a bit of a catch-22 situation with our students. Our students, we always have a waiting list of students who want to do nursing at Queen's and the University of Ulster, and we, as you know, we have the Open University route for people who have worked in healthcare and decide they want to do nursing, and it's very successful as well. The difficulty for us is your student experience is only as good as the mentor that you get and the support that you get in the wards. And if you have, as we have in some of our wards, for example, maybe 60% of the staff in that ward are agency nurses at any given time. That means that the support for the students is left to the other 40%. Not that the agency nurses can't help or support them, but they don't have the same remit for student support as the core staff do. So I can quite, I'm quite sure that some of the students aren't getting a good support system in place in some of the areas, and that's because there simply aren't enough nurses in the system to help and support them. So I do worry about that. My other worry is, and it's kind of related to your question, but not, we have got some data, and I don't have the figures in front of me, but we've got some data that we are losing quite a significant number of nurses in year 2 post-registration, simply because of the staffing shortages again, and the fact that they just say, I didn't come into nursing to not be able to look after patients properly, and they're choosing to leave. Now, that is significant and very worrying for us in the short term, but even more worrying in the long term, because if we lose a big swathe of those people, that's our workforce planning for the future. So, we bring 100 nurses in and we lose 30 of them. We've only got 70 left. So we have planned to have 100. So as you can see, that is storing up trouble for a couple of years in the future if we can't keep these people in the service. And I have to say, it's just unbelievable to me that we have ended up in this situation in Northern Ireland. We have fantastic universities. We have always had good relationships, good stakeholder relationships between trusts and partnership relationships between trusts and students. I mean, our students are so valuable to us, and yet some of the nurses would say that are trying to support them would say, I can't do it all. I can't look after the patients and give the patients care because there's so few of us, and at the same time invest in the students what they need and are entitled to be invested in them. So there are significant, for me, issues ahead if we aren't able to tackle, and they're all of the issues that we're talking about here, all down to safe staffing, because if we had enough nurses to do the work, the patients would get proper care, the students would get proper support, the nurses would be able to support each other, and we wouldn't be facing the mental health and anxiety issues that we are seeing in our members across, and as Fiona rightly said, across every service in Northern Ireland and every trust.
Thank you.
And the independent sector. Sorry, Pam.
Just as a sort of follow-up, Chair, I think that some of the nurses that I'm referring to are thinking that they might drop out already, even in their first year, and it's because there's been an indication from the university that in some ways they haven't met their learning threshold or targets for that, and they might have to be put back until the next intake, if you know what I mean. So they're very liable to walk away. So, and again, it's not to apportion blame, but you can understand how if somebody's really worked hard to get on a course and then feeling that it's not sort of fulfilling their thoughts of what it's going to be. So I suppose it's something that we just have to, as you say, factor into the overall.
I think people need to realise, Paula, and nursing is a very highly academic programme as well as the other side of it. So it is, the academic portion of nursing is quite significant, and I think sometimes people do struggle with the academic part of it. If they're not meeting their learning needs due to the practice settings, and again, then that's a different scenario. So we have to know and understand which of those it is, before we try to put a remedy in place for those individuals.
Yeah, no, thank you. I'll just leave it there. I don't want to labour it. Thank you.
Okay, thank you, Paula. Okay, thank you, Paula, and thank you, Rita and Fiona and Andrew. That is hugely concerning, I have to say, taken across the whole piece. I do think there are a number of issues that the committee will want to pick up on immediately following this briefing and write to the department, although we are conscious that we're heading into a period of uncertainty around the election and what follows that. But one thing that we are agreed on is that the delivery of healthcare and the support of our healthcare workforce cannot wait and must continue. And I think it is stark and disappointing that we have an announcement yesterday around the multidisciplinary teams, for example, being instigated, yet the Minister this morning has already acknowledged that would be, as you have mentioned, Rob and Peter to pay Paul, and therefore you have to wonder, are the staff out there in order to ensure those multidisciplinary teams can be put in place in a way that's safe and protects all the other services? So I think there are issues around that. On behalf of the committee, I think also the issue about mileage review is one that we are, the mileage costs for your staff at this present time are ones that are of huge interest, as is the safe staffing legislation, and the committee have made that a focus across our period of time. We expressed our disappointment it wasn't taken forward in this mandate. We have included it as part of a key element of our committee report, that safe staffing legislation is an absolute imperative. But I want to thank each and every one of you for your attendance today. I want to wish you and all of your staff, on behalf of the committee, all the very best in the time ahead, and to hope that we can see some of these issues being moved on in a way that do work. Because I think what you're saying there is very, very correct, Rita. There's a lot being done, but there's not a lot of evidence that it's working. So therefore we have to ask ourselves honestly and urgently, are the right things being done? Do different things need to be done? Do we need to approach the issue from a different perspective? And we need to see an urgency and a scale of response, I think, that reflects the scale of the difficulties that you're outlining for us. So thank you for that. We will give that some thought as to how we make a final push on some of those issues for you. But for now, I want to wish each and every one of you and the entire nursing workforce that you represent all the very best in the time ahead.
Thank you very much, Chair. Thank you.
Thank you, Chair.
Thank you, Rita. Thanks, Fiona, and thanks, Andrew. Okay, members, there's a few issues there that I think do require us to write to the department on, despite the fact that we're heading into a period of time where we won't necessarily, as a committee, be able to pick up with a response. I think the issue of that whole systems review of the workforce is urgent. I'm basing that upon what we've heard in that session, but also upon the Minister's acknowledgement that even the announcement yesterday, essentially, the announcement yesterday on MDTs may not be realisable given the shortage of workforce. I think the RCN make a very valid point that we need to look at this across the entire system, how it's interacting right from GPs, domiciliary care, the independent sector, and also looking at it from the point of view of what it is we need to provide health services, and not a narrow focus simply all the time on costs or whatever. We need and I think that plan needs to be brought together well in advance of 2026. So would members agree that we write in relation to that issue? I also think we need to put on record once again the committee's concern and the priority that we feel the department should be given to safe staffing legislation. It's going to underpin all of this work. So if members are content, we'll include that. And the third element that I think needs to be written to by the committee as a matter of urgency is around the review of costs for staff and that mileage, those mileage costs, and for something to urgently be done as a result of that review to ease the pressure on staff who are struggling not only to work when they get there. Staff are now even struggling to take on shifts or to travel to work, given the expenses and the costs. So would members agree with that? Okay. Members, thank you for that. So I am conscious, members, that we are keeping an eye on the chamber. There is private members' business taking place that we may need to suspend for. I'll just check with Clerk where we're at on that and see if it's worthwhile starting the next session, and then we may have to interrupt it, or we may, depending on the chamber, get through that session. Clerk, what's your thoughts?
From what I can see, Chair, the Minister's still going through his statement, so there'll still be questions to come, so there might be...
And will there be another statement, or is this the...
Well, this is the final statement. This is the third statement.
So I think if we have the trust staff on the line, I think we'll go ahead, and I'll take then an indication from you, Clerk, if we need to suspend at any time. I think we'll continue and progress on and use the time to the best effect we can. So I'll move then to that session, which is a briefing from the Health and Social Care Trusts. Representatives from the Trust are here today to brief the committee on the situation in emergency departments. This is as a result of the letter that the RCN sent us a number of weeks ago, and we'd asked for this session to be put in place in relation to that. So I'd now like to welcome Jennifer Welch, Chief Executive of the Northern Trust. Can you hear us okay, Jennifer?
Yes, I can hear you, Chair.
Thanks, Jennifer. And I am aware, due to some technical difficulties, we will have some people joining by phone, but I'll work on through as we go. Roisin Coulter, Chief Executive of the South Eastern. Roisin, can you hear us okay?
Yes, indeed, Chair, I can.
Yeah, and do you prefer Roisin or Roisin?
Roisin's great.
Roisin, thank you. Brenda Craney, Executive Director of Nursing in Belfast Trust. Brenda, can you hear us okay?
Yes, I can. Thank you, Chair.
Yeah. Geraldine McKay, Director of Acute Services in the Western. Geraldine, are you hearing us?
Yes, Chair, I can hear you well.
Thank you. And Heather Troughton, Executive Director of Nursing, Midwifery and AHPs in the Southern Trust. So if I could invite witnesses to make brief opening comments, and then we'll go to members' questions. I'll maybe just, because you're first on my list, I'll go back to yourself, Jennifer. Have you appointed someone of the team, or is it you making the remarks?
Yes, it's me making the remarks, Chair, on behalf of all of the trusts this morning, so I'll be brief so we can get on to questions. So thank you, Chair. There's no doubt that the COVID-19 pandemic has had a profound impact on healthcare provision and hospitals across Northern Ireland, which are now facing unprecedented pressures. From the outset, we would all wish to acknowledge the efforts of all of our staff throughout health and social care for their commitment and their actions in continuing to meet the needs of patients and to provide the best possible care. Pressures will invariably be most evident at the emergency department, which, for obvious reasons, is frequently referred to as the front door to the hospital, and the flexibility and the discretionary effort of staff has undoubtedly resulted in safer outcomes for patients. Before the pandemic, there were more opportunities for unscheduled care to work as an entire system. However, despite Director and Chief Executive regional oversight groups led by the Board and an associated action plan, it is apparent that all hospitals are operating at or beyond full capacity, which limits the actions that can be taken. For example, so-called smoothing, in other words, the diverting of ambulances to hospitals where pressures aren't quite as bad, becomes very limited because the capacity just isn't there. The current situation is further compounded by the unusually high number of people who are attending EDs, mostly by ambulance. They're very sick and they require to be admitted. That additional and immediately required capacity is very difficult to cope with, and it demands huge efforts on the part of many, both within the hospitals and the community services, to attempt to ease the pressure. Indeed, there are times when it feels like we simply run out of options and we are limping through on a wing and a prayer. When high numbers of patients are waiting admission to an inpatient bed, space is compromised. It adds pressure to the emergency departments. Many patients are waiting in the emergency departments much longer than we would wish. And however, while access to the ED may be delayed, we continually strive to ensure that patients attending are cared for in a dignified way by the relevant clinical specialist staff and by ED nurses, and trying to take account of the clinical acuity of those patients. In terms of infection prevention and control, which continues to be a major issue, there is continual engagement between all infection prevention and control teams and the clinical staff as they work together to manage COVID issues and other infections which require IPC measures. Daily completion of infection control risk assessments is undertaken to ensure that all patients requiring IPC precautions are prioritised, and the IPC nursing team supports all wards and EDs with daily visits to each of the clinical areas. Naturally, we are very concerned about the mental health and the well-being of all of our staff due to the sustained pressures arising from this unprecedented demand for healthcare. Senior management teams remain focused and committed to supporting staff every day to manage departmental pressures. And the directors of nursing across the region have also acknowledged that the unprecedented and sustained situation often places nursing staff in the position of having to make judgments and decisions that would not have been countenanced previously. And a number of measures are in place to support staff during these times of unprecedented pressures. In closing, I would like to assure the committee that we are all fully cognizant of the challenges for all staff who work in our emergency departments, and of the moral distress being experienced by staff who are often caring for patients whose needs would be more appropriately met within the right ward environment. We are exceptionally concerned that there appears to be no immediate solution to reduce the system pressures on emergency departments. However, we can provide assurance that the pressures are escalated through directors and chief executive regional meetings, and that we will continue to direct all support measures available to us to care for patients as safely as possible and to support our staff as best we can. I'm very happy to take questions, Chair.
Okay, thank you, Jennifer. And I suppose the first question I want to raise with you is around, and I appreciate you've covered an awful lot of the items there in brief, the issue of moral distress for staff, and we have just heard, the moral distress that's caused for a nurse who has to walk past a patient, as we have just heard, potentially up to 100 times without providing that care. That's a huge strain. Do you recognise that, and are there things that can be done in the short term to try to address those pressures or support the staff in terms of even psychological support? Are there anything sort of in the progress at the minute that could provide a ray of hope, or longer term planning that can start to address more fundamentally those problems?
Okay, thank you, Chair. So I'll kick off, and I can talk specifically about the Northern Trust, and I'm sure other colleagues will want to come in, because there are similarities across our EDs, but also there are some differences as well in terms of the actions that we need to take. First of all, we all do absolutely recognise the concerns, and I think the major thing for me is that whenever we're sitting with high numbers of decisions to admit, so I checked literally just before we joined you today, at the moment, a short time ago, there were 248 patients across Northern Ireland's emergency departments for whom a decision to admit had already been made and for whom no bed was available. 51 of these are actually in the Antrim area hospital at the moment. So what that means is those patients should be in a bed in the right ward environment, being looked after by the appropriate clinical team. So they need to be moved on in a timely way to cardiology, to respiratory, to a surgical ward, wherever that may be, and we are not able to do that. Now, there are particular issues at Antrim in relation to there's not enough physical bed capacity on this site, and I will come back to that. So we absolutely do understand the moral distress for the emergency department, who are trying to do an emergency department job at the same time as they're effectively trying to care for 2 or 3 wards worth of patients. And they are skilled as emergency department nurses and doctors, but they are not specialist respiratory nurses or cardiology nurses or whatever the need may be. So we absolutely do appreciate and understand the concern that those individuals will have, because we're not getting patients into the right bed at the right time in a timely way. So we absolutely appreciate and understand the moral distress. I think all of us have put significant support measures in place across all of our trusts across the last couple of years in terms of trying to support staff. So we have psychological helplines, we have team briefings, certainly here in both Antrim and Causeway. We have a very heavy senior manager presence and access to directors every day. I myself walk these sites very frequently and I'm seen often in the emergency departments. That doesn't mean that I can fix it easily, and I wish I could wave a magic wand to do so. It is overcrowded. We are concerned. I do want to mention specifically the physical capacity on the Antrim site, because I do think that would make a huge difference, and it is something that is an important ray of hope for our team here. In the Northern Trust area, we have 28% of the population, but we only have about 18% of the beds. And it is widely acknowledged that Antrim in particular really does not have enough beds for the patients that it serves. We are currently working with colleagues to explore an option to urgently increase capacity on this site up to an additional 48 beds. We're reworking a business case and working closely with departmental colleagues, which we hope to have with them before the end of this month. If the approvals can be given on that in a very timely way, we're working with a particular company to get beds on site very quickly, and we believe that we can have that in place before next winter, so before the end of this calendar year. And that is a really, really important measure for our staff in terms of increasing physical capacity on this site, and that will help us immensely in terms of how we measure, how we improve flow, how we move patients quickly out of the emergency department and onto the right ward. There's a detailed action plan as well, but I think beds happens to be the big issue for the Antrim site, but there are other detailed things where we're all working as well in terms of increasing ambulatory pathways and so on. We have a reform project in relation to our community beds and trying to expedite that more quickly, but the major issue for Antrim happens to be beds. Thank you, Chair.
Okay, thank you. And actually, what I will do is, and I know you had said that some of the other staff members, some of the other members may wish to come out in some particular issues, but what I will maybe do is I'll go to Pam Cameron first, and those answers may be provided as part of Pam's question. We'll see how that goes, because I'm conscious that Pam is due to speak in one of the debates that's ongoing in the plenary session. So I'll go to Pam now, and hopefully that will assist, and then we can pick up on those other points later if necessary. Pam, go ahead, please.
Thank you, Chair, and thank you, Jennifer, for that brief. And it's good to hear about the work that's ongoing in terms of working up this additional plan to get those 48 beds into Antrim Area Hospital, because obviously that it has a knock-on impact on the rest of Northern Ireland as well. It's not to say that Antrim only serves, South Antrim or Antrim. So I think it's really important, and I did ask the Minister about that earlier, and I do hope that you're getting the priority that is required in terms of response from the department on that, because that's really critical going forward. I just want to ask you a quick question to Jennifer and to the other trusts as well around what's happening with the domiciliary care packages at the moment, and what kind of numbers of people are currently waiting for packages in order to be discharged, and how that has varied in recent months.
Okay, thanks, Pam. I'll kick off in relation to that. Domiciliary care continues to be a challenge for us, and there are particular pockets that can be more pressured than others, particularly Antrim, Ballymena and the Mid-Ulster area currently. We have been working closely with our independent sector providers, and where dom care packages are not available, we are trying to get some rapid response services, or even admitting people to a care home for a short period of time before we can access the package. It is compounded by the fuel pressures that you would have mentioned earlier on. Certainly staff are experiencing that, and we do have some companies who are feeling the pressure and talking to us about potentially handing back packages as well. As you know, we do have some home care services within the Northern Trust that we provide, as well as contracting with the independent sector provider. So we are doing our best pick those up as best we can. In terms of ongoing delays, what we're trying to do, Pam, is a variety of things where maybe we cannot complete a full package. So we're trying to work with families, for example, where a patient might, or a resident might need, for example, 4 visits a day. We're trying to work with families to say, at the moment, we can provide 2. Can you help us from a family perspective? So there are all manner of ways that we're trying to resolve this, but there's no doubt there are too many people waiting currently, and it can't give you a precise figure because it fluctuates often in relation to, you know, we get some people sorted out with the package, but equally then there can be several more come onto that list, so it fluctuates on a daily basis. It had improved slightly from where it had been earlier in the winter time. And things were looking better, but I have to say I have become more concerned now because of the fuel pressures. So we think things will continue to go back up again.
Okay, thank you. Go ahead, Pam. Have you anything further?
Chair, I don't know. I was just going to ask if any of the other just want to comment on that as well, and I suppose to go back to Jennifer and ask you if the £23 million investment into domiciliary care, has that not impacted? It doesn't sound like it. It doesn't sound like it has impacted in a positive way.
Well, I suppose I'll just answer that bit. We did see it starting to impact. We did feel that things were actually improving and stabilising in certain areas, but I think that has become concerning again because of the fuel costs. So we do have a varied picture, and some localities are a bit more stable than others. But I think it also has to be considered in terms of community transmission and the level of absence that we're all experiencing. So, for example, within the Northern Trust at the moment, our absence for normal sickness absence plus COVID is currently sitting at 12.38%. So we know our independent sector providers are struggling with that as well. High levels of community transmission, and they've also got high levels of absence. So while I'm pretty confident that 23 million was passed on to their employees, whatever it is, a COVID positive situation or the need to self-isolate, that's compounding the situation, and then the fuel costs now on top of that as well.
And thank you for that, Jennifer. And I suppose just quickly before I go here, I suppose that kind of answers the next question I would have asked, which was around staff absence. And I assume then the isolation requirements haven't been adjusted as they, in terms of how healthcare staff have to react to COVID. I take it that hasn't changed. Will that not change as we, hopefully are starting to emerge from the pandemic? Surely those the rules around that isolation need to change as well as it has with the public more generally.
Well, we can't afford to take that risk. I mean, there is guidance that we follow in relation to risk assessments and bringing staff back from work. But what we have found in practice, it's actually very difficult to return staff early to clinical areas. And we have found that people who have been exposed, they might not test positive on a lateral flow to day 8 or day 10 post-exposure. So we do have a process of requiring our staff to have a PCR, which is negative before we can return them to work in a timely way. Obviously, some staff can work from home if you have an administrative type of job like mine, but where we're really feeling the pressure is those frontline clinical teams. So it remains difficult, and we cannot afford to take any risks in those circumstances.
Okay, thank you very much, and thank you for the good work we're all doing. Thank you.
Thanks, Pam.
Okay, thank you. And going then on the video link to Carol and Killen. Go ahead, Lana, Carol.
Thank you. I'm really concerned, I have to say. I mean, I understand that you also appreciate how difficult things are, but we have a situation where there is a crisis, particularly in relation to emergency care, and it is distressing, but it's also been described as unsafe. So what exactly are the trusts doing to provide safe staffing conditions? Please, that's my first question.
Yep. So
Chair, would you like me?
Go ahead, Jennifer. Do you want some of the other trusts maybe to pick up on that as well, or?
Yes, if somebody else wants to lead on that, I'm happy to comment as well.
I'm happy to start off, Chair, and then I think that, specifically it might be quite useful to have one of our directors of nursing speak particularly to this piece. That might be useful. First of all, I just want to say, thank you for the ongoing commitment from the Health Committee to supporting all of our health and social care services over the last while, particularly during the pandemic. I suppose what I would want to say is that the points that Jennifer has made, I'll not repeat them because they do apply right across the piece in terms of the challenges that our services and then our staff are facing. This is certainly the most challenging period of time that I have ever faced in my own career, and I suppose we're all on the same page that we recognise it's not one thing. There are so many just different parts of this jigsaw that it is, it is a massive system issue. The first one, and I know listening earlier, the Royal College of Nursing particularly concerned regarding nursing workforce, and workforce needs to be the first point of call in terms of planning for a short, immediate, medium and longer term workforce strategy right across all of our professions, because some of these solutions take years to deliver, and we're very aware of that, because we can talk about beds, but if we don't have the staff to actually support those beds, then that is a very significant challenge. So the workforce is really important, as is the capacity that Jennifer mentioned. And just for example, in my own trust, we've also we're very pressurised, and we're trying to do something very similar there, and have managed to put in place an additional 45 beds. But the key thing as well is it's not just about the physical infrastructure, it is not just about building beds, it is about having a system with a future planning model and the Commissioner having the investment and the funding available to fund the staff to care for patients in those beds. So, for example, we have been able to mobilise those beds, but the money is non-recurrent. So in 2 weeks' time, officially, there is no money to continue staffing those beds. So as a system, hopefully, you will hear there's a need. We have to continue, and we need to find a way to do that. A couple of other points I would want to mention, though, is always to say, we know that the pinch points, as Jennifer said, and others, is at the front door, and we're all supporting our staff in ED with some of the most distressing situations that we find ourselves in, and it's very, very difficult. And I have seen it firsthand, and many times staff almost at breaking point, and I know the Royal College of Nursing are doing a good job in supporting our staff concerns. We are absolutely in agreement that the situation they're finding themselves in is unacceptable, and that they can't deliver the care that we always want to. That's really important. Pam asked, and Carol then, what are we doing to ensure safe staffing? Well, we are doing everything we possibly can, but staff and nurses and other professions don't grow on trees. So, for example, it's not widening out the picture. In social work today in the South Eastern Trust, there are 40% vacancies. To me, that's really concerning. It's alarming, and that's part of the issue about being able to manage overall flow. So we've talked about the front door, we've talked about the back door and back out to home and domiciliary care, but you need a social work profession to be able to support the flow of those patients. And I do think then we're into a space where we're looking creatively at, what other roles and job opportunities might be available for people to come forward. And I do think the skill mix is something that's going to be looked at, and welcome external reviews in relation to professionalisation across a number of professions in Northern Ireland. So, for example, in the ED, but not only, we've looked at support for our staff on the front line, whether it's, helping to transport, helping to feed patients, helping to care for people with dementia who are, more vulnerable within our emergency departments. We're all doing all of that. So, we can't magic up always professional staff, but we can augment that with support teams as well. But I would, my points were really regarding, really addressing the system needs here. The demand is well above the capacity. That's a Northern Ireland executive issue for us all to look at as trusts. We're responsible for providing the services we are commissioned to deliver, but the demand is just so great. And yes, there is the need for transformation, and we are all wanting to do that. We're all meeting together as a system every single week, looking at some of the real opportunities, and hopefully things will continue in a short period of time, that we can take forward a number of the reviews of services, in particular the one at the moment in relation to urgent and emergency care, that offers an opportunity to do things in a different way and and really to work across the system. And I would want to refer to supporting our NIAS colleagues and the pressures that are there. And my final point is in relation to looking at what increasing demand, looking at what we need to commission in terms of services, supporting our staff. But finally, for me, it is really about public messaging. It is about explaining to the public, with the level of investment currently available in Northern Ireland Health and Social Care Services, what it is possible to provide and also what it is not possible to provide. And there are big choices that need to be taken. And the Trust, we are happy to work alongside all of our local elected representatives, community and voluntary sector partners. But we're going to need a radical, very strategic, high-level master plan for how we will rebuild services outside the pandemic. And honestly, I couldn't come off my session here without saying, yes, unscheduled care is a real priority, but we know the elective waiting lists in Northern Ireland are longer than anywhere else in the UK, and that there are people coming to more harm on our waiting lists than there are in other areas of the service. So it's just about us looking at the whole picture, I suppose. So hopefully that's useful. Thank you.
Okay, thank you. That's fairly comprehensive. Just if there's anything anyone wants to add briefly in relation to that, I know that's a lot of it covered there.
Chair, this is Julie, and I would like to add just a couple of things that we have done in terms of enhancing and supporting the staff within our emergency department, particularly at Galvin, where there's huge pressure and it's been unrelenting now for a number of weeks and months, as Jennifer and Roisin has alluded to. So in terms of multidisciplinary team, we know that a patient pathway requires a lot more support than just nursing. So we have gone ahead and added the multidisciplinary team into the front door of the hospital. So we have a wider range of service for the patient, and we hope to avoid admission, and we have been avoiding admission. And for those patients that Jennifer and Roisin referred to that are waiting every morning for inner ED departments for admission, in terms of ensuring that their basic care needs are met, which our ED nurses sometimes need support with, we have put in place a number of other supporting healthcare assistance to ensure that patients receive toileting and receive catering and food and all the necessary support that they would get. And in addition to that, because families are not accompanying their relatives into the department due to overcrowding and other issues with COVID, we have put in place family liaisons. So we have people who will support the nurses to liaise directly with the families on a daily basis or every number of hours, just to make sure they're kept up to date with their care. But you've got a feel for the service that we're currently providing from our other two chief executives.
Okay, thank you.
Chair, may I can?
Yes, go ahead, Brenda, and then I'll come back very briefly to you, Carol, but go ahead, Brenda, first.
Okay, thank you very much, Chair, and thank you, Carol. I do think it's important as Director of Nursing, and I'm sure Heather would agree, that we endorse everything all of our colleagues have said to date. Key to supporting staff at the minute is to be with them and listen to them and work with them to put in place new ideas, which we have done across all of our trusts, and certainly that has given us some immediate improvements in the safety, but overarching, we do not have enough capacity, as colleagues have said. Like other colleagues, we have opened up additional spaces, but that is at the expense of other services. So similarly, we have opened up 40 plus additional beds in Belfast, but that's in areas where Elective care would normally happen. So obviously then the patients who are due to go through those areas cannot, and it is impacting our ability to offer services which are equally concerning. And the final point I would like to say in relation to support of the ED staff particularly, we are employing nurses who have different roles to support the ED, but again that's not sustainable in the long term. So overarching, it is the workforce capacity and the unprecedented increase in attendance that we're struggling with at the moment, and I fully respect, and I have to say I am a Royal College of Nursing member, I respect and support the nurses who have raised escalated their concerns in a professional manner, and we're very committed to working with RCN and indeed other professional groups to improve the situation. But it is a system situation. It is not just one fix that will make this work, and certainly we will have challenging days and weeks ahead. Thank you, Chair.
Thank you, Brenda. Carol?
Chair, for time, and but I do say the fact that the RC said they're not included.
Carol, just it's very hard to hear you again. Could you try the camera off again, please? We're losing every other word.
Sorry, Chair.
Yeah, try that now, Carol, please.
Okay, so committee not so long ago that they, first of all, they're not getting any data in terms of workforce where it's lost out. They've got anecdotal information. They also said that they weren't included in the formation of plans. And they also said that they feel that it's very, very vulnerable. Now, I appreciate that there's a situation beyond your control in terms of we don't have a First Minister. We have £23 million in elective care that we can't spend. And we're running towards the end of March, so that's the non-recurrent funding, and you don't know what's in front of you. But the issue for us is that we heard a plea this morning, and while we hear that you really understanding of that and you're trying your best to fix it, it does sound like between colleagues in the ambulance service and those in emergency care that whatever's happened isn't working well enough, and we you know, if there's a serious adverse incident declared every day, what would happen?
So a brief answer from one, please, in relation to what would happen in the event of a serious adverse incident or serious event being called. Jennifer, you're on mute. Go ahead, Jennifer.
Thanks, Chair, and Carol. Thank you for that question. Look, this is very serious. I take it you mean what would happen if there was a major incident, so a very significant event that required support from various emergency departments. We have talked about this, and there are times when we would struggle to cope with that. I have to be quite honest. You'll be aware from media that we have had a potential major incident at Antrim Area Hospital. We are very close to this all of the time. And as I say, Antrim does have particular issues due to there's not the capacity on this site. I envy my colleagues who are able to open up additional beds because they have physical space. I have no physical space to do that. So the times that we are most worried is whenever the department is beyond full, it's overcrowded, and that we have patients in trolleys, on corridors, we cannot get them to a ward, our resus is full, and we would struggle, if there was a major incident at that point, we would struggle to be able to respond appropriately. That is the truth. And as I said in my opening statement, it used to be that maybe individual sites would get under pressure, and we would work very closely with our ambulance service colleagues to divert ambulances away from the site that was under pressure. And we still smooth to a certain extent, but our ability to bail each other out is just not there because we are all under such pressure. So I want to fully echo what Roisin has said. This is beyond something that individual trusts can do. All of us have put in extra resources, beds where people can do that, additional staffing where people can do that. And we're all running on significant amounts of non-recurrent money because we have brought in additional staff, we have brought in agency staff, and we do not have the permanent funding for this. So that's part of what we do to try and make sure that things are as safe as they possibly can be and to support our own staff. But it is beyond the ability of individual trusts to fix. There is an issue here at a regional level in relation to what we're currently commissioned to provide. and what Northern Ireland needs. So the demand is much greater than we are able to provide currently. And it does need to be an entire system approach, looking across our urgent and emergency care, the flow right through our system, but also our elective as well. As Roisin has said, there are many people who are waiting far too long on our elective lists, and some of them will deteriorate while they're on those elective waiting lists, and they will then present to an emergency department. So I can't underestimate just how difficult and challenging this actually is to be able to continue to manage this on a daily basis. I have to say, it does feel like firefighting every single day, and we urgently need to get more capacity right across this system. For some of us, that is beds. It is about additional staff. It is about getting the entire pathway through our acute and community services right.
Okay, thank you, Jennifer. And going then to Deborah. Deborah, go ahead.
Thank you, and I will just go straight to some of the questions that I have. I'm not sure if it was covered in some of the answers, but I just wanted to check for clarity. In terms of the nursing staff that have been abstracted from theatre functions, have they returned, and have any levels of elective care surgery been scaled up in recent weeks? Now, I know that we've heard in the past at Health Committee and even today in relation to Musgrave Park Hospital and the difficulties that surround that in terms of nursing staff, and that it may not be at a level that can even function even if staff do return to that. So could you maybe just indicate where we're at on that in terms of staff?
I think, Brenda, do you want to come in, given the questions around Musgrave Park?
Yes, can you hear me?
Yeah.
Okay, thank you very much. We have opened up some of our elective theatre lists in Musgrave Park, and staff are in the process of moving back. You appreciate that we redeploy a large number of staff from Musgrave Park teachers to staff our critical care areas in the Royal, the City, and the Ideal when it was open. Has come with its own challenges, and I heard Rita from the RCN say earlier that that's not staff's first specialty, which is very important to acknowledge, but we a lot from our redeployments as the pandemic moved forward. Theatre nursing, however, it has had its challenges in recruitment as well, which also impact our lists. And before the pandemic, unfortunately, we had a number of lists downturned in respect of workforce. We're doing a big piece of work in it, not only to get those staff back into their areas of choice, but also to improve our peri-operative workforce. And I'm pleased to say that has been successful, particularly with overseas recruitment. But it does take some time to get our overseas recruits onto the register and fully ready to work in the workplace. But at the minute we are bringing in between 30 and 50 overseas nurses per month, and we're on track to complete our work in that arena at the end of March. I do think it's also very important, however, to note that the redeployment has an impact, and some of our staff have decided they didn't wish to be deployed, and they have left. We have to learn from that, and certainly as colleagues will know, we have lots of nursing vacancies across Northern Ireland, so nurses have the ability to go and work where they choose, and certainly we're looking at that going forward. And the retention survey that we referred to, which is difficult reading, does note redeployment as a factor, our staff wishing to remain with us. But in respect of our elective work in Musgrave Park, and you will be aware we also have the City Hospital as what we call green site. So we're managing a large amount of our elective work through the City Hospital, but there are certain services that have to be managed through the Royal, and that's in relation to major trauma, neurosurgery, cardiothoracic surgery, and their regional specialties which need to remain through the Royal. So they are the complexities we are dealing with in ensuring we have the theatres fully staffed. achieved a lot, but we certainly have more to do in this area. And it is a regret to me that nurses have chosen to leave because they were not happy to be redeployed. And we need to look at how we do that better going forward.
Okay, thank you. And in relation to the South West Acute Hospital in my area, there's been some particular pressures just in relation to staffing and one thing and another. And I know that there was international recruitment that was put in place for that. I was just wondering, is there any update in relation to that, and in particular the neonatal services at the SWA at the moment?
We're still recruiting to the neonatal service at South West Acute Hospital. We are out through international recruitment at the minute. There are other services there that are also coming in through international recruitment, general surgery being another. We've had some success in terms of general surgery. I don't have the neonatal figures with me, but I can get them for you. But the service is still up and running at this stage and will be maintained going forward and is being managed. I just want to come back to the theatre piece. We have 28% vacancy in this trust in terms of theatre nursing, and that has been the case for at least 2 to 3 years, long before COVID came to hit us. Theatre nursing, as you heard earlier from our RCN colleagues, is a very specialised area, and it takes a long time to train nurses and to maintain them and sustain them there whenever we have them trained. All our nurses who work from theatre that were redeployed to critical care have been returned to theatres at this stage in this trust, and they have I suppose they were majority were new registrants who came in through last year's recruitment around August time, so it will take a period of time to get them trained to the capacity of being able to deliver theatre nursing to patients. We are about 65% of our elective activity compared to pre-COVID percentages, so we're on a journey and we are phasing it up, but we're not completely there yet. Thank you, Chair.
Okay, and just very briefly and lastly, I just wanted to ask around visitors to hospital sites, because I have been dealing with a number of families who obviously they have elderly family members who are in EDs waiting for beds, and I'm thinking in particular about patients who maybe have dementia or Alzheimer's, and family members who would visit would come in and take on a role that maybe is now with nursing staff in those areas, and that can be particularly difficult. I'm just wondering what the situation is across trusts. Is there equality across trusts in terms of visitors coming into those hospital sites to maybe look after those particular patients? I'm thinking about, lunch, dinner time, things like that. And also I'm looking at particularly maternity wards as well, because I know that has caused a huge amount of distress to families, and particularly women who are maybe going in for their first time to have children. So if you can maybe answer just around those aspects as well, please.
Yeah, so a brief answer maybe across the trusts there in relation to that issue, please. I'll go ahead and start with Geraldine, maybe just saying as Geraldine, and then we'll pick up on the rest, please. Thank you.
Okay, in terms of visiting, our visiting is reviewed weekly by senior officers within the trust, and given the high transmission rate currently in our geography and in rural areas in particular, the band area being one of them, we have maintained our one person from 1 hour per day at this stage, and we do ask people who are coming to ED that are vulnerable or need support to bring one person with them. I think it's really important to say that our COVID patient numbers have increased greatly in the last 5 to 7 days within the West, and we are now back at high surge levels. So we're at this minute in time communicating with our public around that, and you may have seen messages in the media. So it's kept under constant review, and we do, as I say, review it on a weekly basis and change as necessary.
Okay. Yeah, Brenda.
Thank you, Chair. At the minute in Belfast, we have, as a standard, twice weekly visiting from 2 nominated family members, and that is due to the increased incidents we have across Belfast. Having said that, we do apply more compassionate visiting guidance in relation to maternity care and the Children's Hospital, and certainly we are very keen to provide the care partner arrangements for vulnerable people or people who have dementia or particular needs. And certainly the example you give in relation to supporting the mealtime experience and supporting the general care, I have to say relatives have been really supportive of us in doing that. The one caveat, to be very clear, is where we have an increase in outbreaks across our acute sites particularly, that is a challenge, and there are times we need to restrict visiting because of the situation on the wards, and as Geraldine has said, the numbers are increasing of people we're seeing, and interestingly for us, we're seeing a change. People are actually presenting with a surgical problem or a cardiology problem, but on routine testing they are then testing positive. So that actually potentially increases the number of contacts. And whilst people are tested in the emergency departments, we have rapid testing, and they may negative at that point. They may, with no symptoms, test positive 3, 4, 5 days later, and that adds an additional level of risk, which is why we're trying to reduce the footfall across our sites. Like colleagues, we review our visiting weekly, and we work very closely with Department of Health colleagues, and certainly in situations around palliative care, end of life, and the other examples I've already given you, we will provide compassionate visiting arrangements for specific families, and we risk assess and review this. We actually had this discussion yesterday. We discussed the executive team, and we have decided to keep our general visiting as is at the moment because of the increased community incidents, but we will review that again next week. Thank you.
Okay, thank you. And just maybe really briefly then, and only anything additional, if anything additional then from Heather maybe, and then I'll go to Jennifer and I'll finish with Roisin. Heather. Just check your mute, Heather. I think you're on maybe mute. Check that for me, please. No. Okay, Heather, we're not hearing you at present. I'll go ahead to Jennifer and then Roisin and come back to you. Go ahead, Jennifer.
I have nothing really further to add, Chair. We support the care partner role, and particularly trying to provide compassionate visiting at end of life stage. So very similar position to others, and reviewed weekly.
Thank you, Jennifer. Roisin.
And exactly the same, Chair. The only two things would just be to say we're all doing, individual risk assessment as required, because so many of our facilities are in different conditions to others, so it's not just a blanket approach. And the other point on a positive note is that a number of us have now further opened up support and visiting in maternity settings, because I know that's something a lot of people are very concerned about. So, for example, we now have a partner can accompany the woman at all appointments, including the birth and scans. So, there's progress in relation to that, but we have to keep it under very careful review, as others have said.
Okay, thank you. And I'll just check back, Heather, have we got your sound?
Can you hear me now?
Yes, thank you, Heather, we're hearing you.
Okay, thank you. No, we're very, very similar to my colleagues, and we review it every week, and we keep it as open as we can. We just try to balance the risk between the local prevalence, community prevalence, maintaining our patient safety on the ward, looking at our number of outbreaks, but being as open as we possibly can. And we do have, as well as visiting twice a week for everyone, we have exceptional visiting for, as you say, those patients who require that little bit of extra support, and of course the end of life. So very, very similar picture, Chair. Thank you.
Okay. Thank you. Okay, listen, I think that's all we have time for today. I'm certain we could have run a complete health committee meeting with yourselves, just in light of the pressures you're facing, in light of the difficulties that are out there, and we would have loved, I'm sure, to get on to discussing more of the solutions. However, you will be aware from probably watching in on the earlier sessions that the committee is extremely concerned around the whole workforce issue, around the issue of safe staffing, and around the issue of the pressures that your staff are experiencing around mileage and the cost of fuel. And I know that's a bit probably beyond anything that you can do, but it's certainly something that the committee are engaging with the department on, even at this late stage, to try to get something urgently done in that. But I want to thank each and every one of you for attending today, and indeed for attending committee at various times throughout the period of the committee. So thank you, Jennifer, Roisin, Brenda, Geraldine and Heather. And I wish you all the very best in what are continue to be difficult and challenging times in our health service. Thank you.
Thank you, Chair.
Thank you very much, Chair. Thank you.
Thank you.
Okay. Thank you all. Okay, members, so we'll take a break there. I'm conscious the debate is ongoing and some members are involved in the debate in relation to the preservation of records, a very, very important, actually, issue in the Chamber. I think we'll take a 15-minute break there and come back in 15 minutes, or when the preservation debate concludes, whichever is soonest. So we'll aim for 15 minutes. If necessary, we might take a few minutes more to allow that debate and votes just to wind up. So we'll come back at 5 to 1. Thank you.
This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber.
Okay, thank you, members. So we're back in session now for hopefully the final part of our final Health Committee meeting. Just before I go on to the SRs, I suppose I want to reflect on significant concerns being raised by the trusts there. And one of the things I wrote down at the very outset of the briefing was, I suppose, hugely concerning, was the idea that the service is limping through and on a wing and a prayer. And I think that's really something that we need to reflect on, and something that it's in keeping with what we raised in the previous session in terms of what we're writing to the department on, but it also does reinforce that level of worry around that all. Carol, go ahead, please.
Sorry, yeah, Chair, I agree. And if there was a major adverse incident, what I heard from our Health and Social Care Trust is that they couldn't cope. So it's basically like a fingers crossed approach. So that's one element. And then the other element is that staff really comfortable, and we need that addressed. And the 23 million that the Minister has bid for that can't be used because we don't have a First Minister. So maybe we come back to it in AOB and just try and, include that in correspondence.
Okay. Okay, anything else, members, then, in relation to that before we move on to the SRs? No? Okay. So, members, the first SR is 2022/109. I'll refer members to the papers at tab 8 of your pack. The Department advises this proposed statutory rule will allow for an independent appeal panel to be established for family practitioner services. The regulations will be made under the Health and Social Care Act. I'd remind members that the committee was briefed by departmental officials at the SL1 stage on this SR on our meeting of the 10th of February, and the committee had agreed that it was content that the SR be made. The department advises that there have been no changes to the policy content since the SL1 was submitted to the committee. The Examiner of Statutory Rules has not yet reported on this SR, which is subject to the negative resolution procedure. So do members have any issues they wish to raise in connection with the statutory rule? No, members are content, I think, broadly. So therefore, I would ask members to agree formally that the Committee for Health has considered SR 2022/109, the Health and Social Care Family Practitioner Services Independent Appeal Panel Regulations NI 2022, and, subject to the report of the Examiner of Statutory Rules, has no objection to the rule. Are we agreed? Agreed. Thank you, members. Moving on to SR 2022/122 in relation to international travel. I refer members to the papers at tab 9 of your pack. And members, the Department advises that this SR comprises a revocation of all the regulations governing international travel made in consequence of coronavirus. The Examiner of Statutory Rules has not yet reported on this SR, which is subject to negative resolution procedure. Do members wish to raise any issues in connection with the rule? I think the only one that I would want to raise is, I think there is a general concern out there that the further variant of Omicron, that BA2 variant, is causing significant levels of infection. And just I think it's worth making the point that it is important that a very close eye is kept on all this at this present time, and where there needs to be rules brought forward, that needs to be done on the basis of urgency and the basis of of effectiveness, and very often time is of the essence in these things. So I think that's one of the things. I'm conscious that we all welcome the fact that we're able to relax some of the rules at the minute. However, I don't think we should allow any complacency to creep into the system in relation to COVID. It requires significant, and it requires that we continue to play our part in the global response as well. So we can't simply let our guard down here, and we should be continuing to track the progress of transmission and providing that information on an ongoing basis. So I think that's the only issue I'd want to raise. Any other issues in relation to that regulation? No. So, members, then I'll ask you to agree formally that the Committee for Health has considered the health protection, coronavirus, international travel, operator liability and information to passengers revocation regulations 2022, and subject to the report of the Examiner of Statutory Rules, has no objection to the rule. Are we agreed? Agreed. Thank you, members. Members, moving on then to the committee's legacy report. I refer you to the draft legacy report at tab 10.1 of the table of papers. I would just ask the clerk to take the members through the report and maybe more accurately any changes that have been made that we're looking at today.
No problem, Chair. Sorry, just bringing it up now. During discussion on Tuesday, there was a couple of wee issues brought up by the Chair in relation to the issues raised. So I have made the amendments as discussed. So if you look at it's page 36, your table pack, and in relation to issue 2, first of all, transformation, I've included a line: as part of transformation rebuilding, there should be consideration of an all-in approach to the provision of services, including pathology service paediatrics, which was mentioned on Tuesday. In relation to issue 3 in workforce, then I've included the committee would also outline the importance of the safe staffing legislation being brought forward early in the next mandate, which again was something that was mentioned. In relation then to the budget and the expenditure for the committee, we did identify that in relation to additional meetings, the costs were 2,148. So we've separated them. So that's at page 44. We've just put an extra column in just to outline that that was the cost of the additional meetings for meeting in recess periods.
Okay, thank you. So those all seem as kind of discussed. Okay, is there any other issues that members wish to raise in relation to the legacy report? Are members therefore content with the report as drafted? Mm-hmm. Yep, thank you, members. In relation to the publishing of the report then, members, can I ask that the Committee for Health is content for the Committee for Health Legacy Report for 2017 to 2022 to be published? Are members agreed? Yep, thank you. And are members also content for committee staff to make any necessary formatting changes in advance of electronic publication? Are we agreed? Yep, thank you. Moving on to correspondence, members then. And I am aware that there's not a lot we can do in relation to correspondence. However, there's some correspondence received from individuals which I would ask, if members are content, we forward to the department and ask that the department reply directly to the individuals in those cases. If are members content with that approach? And then, are there any other comments in relation to any particular items of correspondence? No, thank you. Members, moving on to table papers. At tab 11.30 of the table pack, there's an SL1 from the Department on the provision of health services to persons not ordinarily resident. The correspondence advises that as part of the response here in the north to the conflict in Ukraine, the Department is intending to bring forward a role that would allow Ukrainian visitors who are lawfully here but are unable to return home to access publicly funded healthcare can do so here in the north without charge. So obviously that's has come very late, but it is understandable in the sense that the crisis in Ukraine and the absolute travesty of the situation that's going on and the difficult situation for people, that this is a necessary probably SR in relation to providing that healthcare. So would members be content with the department bringing forward the rule in that regard? Yep. Members content. Do members have any comments in relation to any of other table papers items? No. Okay, thank you. I'll go then to any other business then before I give members an opportunity maybe just to reflect, but I'll go briefly to any other business. Carol, you had said there was something there in AOB you were looking to raise?
Yeah, Chair, I'm just going to keep my camera off because I still no internet yet. So 2 things, Chair. I think we need to, first of all, include in our correspondence to the department the deep concern that we have regarding emergency care. I also think we need to put in writing that our regret as a committee that certainly the resignation of the First Minister and indeed the result negative to year budget is impact to allow local planning. It's also massive impact to tackle waiting lists and fund cancer and mental health services, and indeed transformation right across health and social care. So I mean that would be, I'm looking that to be a proposal if we could get that agreed. And the second item I have is that I was just chatting to some of the recently in relation to neurology, and they wanted to put their thank you to every member of the committee and all committee staff for the support that they received from this during this mandate, basically. So that's me, Chair Johnson.
Okay, members, any comments, or are members content that we do express our regret that is impacting on the ability to provide a budget? I think it is reflective of the concerns we've heard. So are members content, Paula?
I just want to also just flag up the fact that in the Chamber this week I asked the Finance Minister around this new cancer strategy. It hadn't actually launched by the time I asked the question, but I said what will happen, because the cancer strategy includes new actions, and he said that he had put forward a full allocation of funding for this year for the cancer strategy, but obviously with the budget not agreed by the Executive, it would be difficult to see that taken forward. So I think it's very disappointing, not least because we want and need a lot of the services in relation to cancer expedited and brought forward to save lives.
Yeah, members.
Sure.
Yes, is that Pam? Is it?
It's Orlia.
Orlia, sorry, go ahead, Orlia.
You're okay. Yeah, no, just to second Carol's proposal, and obviously the addition that Paula made there around the cancer strategy, the mental health strategy. The Minister actually referred to it himself in his own remarks earlier on this morning in terms of, those strategies, the capability to deliver on them has been scuppered as a lack of the lack of progress around the draft 3-year budget. So just want to say that I support Carol's proposals that have been made for the committee to take a position.
Okay, and maybe just to be clear on to capture all of that, that the wording would be that this committee regrets the resignation of the First Minister and the resulting inability of the Executive to agree a multi-year budget to allow long-term planning, tackle waiting lists, fund cancer and mental health services, and transform health and social care.
Chair, can I come in there just briefly? I do just wonder, even if the First Minister was in place tomorrow or today, would the budget actually be agreed in full? Because, when you look at other departments and what some of the other ministers have said, I mean, they weren't happy about the budget either. So I do just wonder if it was the case that the First Minister was in, would it actually be agreed? I think there would probably still be tweaks that an awful lot of departments would like to make to the budget. So, look, I know if it goes to a vote, I'll probably be outvoted in relation to the proposal that's before us, but I think it's important to put that on record, that I'm not sure all departments are actually fully in agreement with the draft budget and what was in place. And it is also the Minister's responsibility as Minister for Health to plan. And, you know, I think also we have to be realistic that even if we're in 1 year budgets or 3 year budgets, we still must have an ability to plan within the health service and look forward, you know, as well in relation to the services and the population that we have in Northern Ireland. So I just want to put that on record, Chair. Thank you.
Yeah, thank you, and that's fair enough. That is fair enough, Deborah. I suppose there is a hypothetical consideration there, but I suppose, you know, in terms of being a real, genuine, present concern, I think the warden probably does reflect the committee's views. Okay, so I think the committee are content to agree that position broadly, and your points are on the record, Deborah. Thank you. Okay, members. I don't have any other indications of any other business, and therefore I just want to move on to some remarks from myself in relation to the committee. And I just want to first and foremost thank every one of the committee staff here who have guided us through what has been, I think, an unprecedentedly difficult period, I have to say. And they have done that with aplomb, with grace, professionalism. They have facilitated multiple changes to meetings. They've arranged multiple briefings at very short notice and moved things around. I don't think any of us fully understand or ever will fully understand the amount of work that went into that. So I want to thank all of the staff. In particular, I want to thank, thinking today about Ailish Haughey, who was the original clerk here, and the first clerk that I had ever worked with. And she did a hugely professional job with what was poor enough material sometimes in terms of being a committee chair, but she guided me through that period. Also Keith, who has picked up that baton and similarly been available at every hour of the night and day, and including I think certainly Christmas Eve. I know for sure. I'm not sure if Christmas Eve, but if Christmas Day came into play, but it probably very nearly did. But I know that no member of this team has ever, in any way, indicated that they were under pressure or not available to take calls. So I want to thank Keith, Jonathan, Roisin, Deirdre and Brenton, and all of the other committee staff who at different times took on roles that aren't here today. It's actually wonderful to be sitting here today. It's the first time in so long we've all been able to sit here. But I have to say, we absolutely could not have taken on the massive role that it turned out to be for a health committee without the professionalism, diligence and hard work of yourselves. I also want to thank the wider Assembly team here, including the cleaners and the security staff and all that, for the very professional and friendly way they go about all of their work. And it has been noticeable to me that there hasn't been really significant outbreaks of COVID here in the Assembly as such, and that's largely down to those staff who are in cleaning constantly and all the rest of it, and maybe under acknowledged sometimes. But I want to just personally and on behalf of the committee thank them for the very friendly way and the very friendly atmosphere they create and helpful atmosphere they create within this building. I also would extend that across all of the different directorates here in terms of, you know, the building and events and all of those various support teams that do so much for all of us as MLAs, sometimes again unnoticed in ways. I want to thank my own policy team and my own all of the people who worked within health within our own. They too were dragged along on that journey of having to go through packs that were sometimes over 1,000 pages long, having to be scrutinised, having to pick up, and the huge amount of work that my own team in relation to all of that have done over a period of time. Again, morning, noon and night, weekends, holidays, nothing was sacrosanct at any time, and again, those people are the people who keep the wheels turning and provided guidance and all of that. I do want to thank the members, and I have to say, and a lot of people have remarked to me that the Health Committee, they believe, has been very effective. I think that's actually down to members. I think the members, first of all, passion, interest, commitment and focus on health. We have been very lucky as a committee in the sense that we have had genuinely interested MLAs who are expertise in various ways and cover a lot of the different elements of it among each other. I have remarked often on the fact that we have had virtually 100% attendance over a period of 2.5 very difficult years, which put pressure on sometimes on times, But I think the focus and dedication of Health Committee members has made my job much easier. I want to thank each and every one of you for your integrity, your honesty, your help and assistance to me at times as well, and your tolerance and at times where things have been difficult. And I also want to include all of those members who have come as part of the committee at times, and I think, and then moved on to other things. I think the committee, as a corporate body almost, has taken a very constructive approach and has worked very closely with the department, with the sectors, and we have engaged massively. The fact that we've engaged with over 1,000 or well over 1,000 organisations there in a short period of time across briefings does indicate a committee that hasn't just talked the talk about co-production and engagement, but we have actually walked that walk, and we have demonstrated the value of it, the possibility of it, and the practicality of it. So I want to thank that. Just briefly, thank my own family in terms of this past period of time has been quite difficult at many times as well, and sometimes they have been the people who have lost out, so I just want to thank them for that. And finally, I want to end by thanking the Deputy Chair, Pam Cameron. And Pam has absolutely made this and has contributed to the work of this committee massively. I have to say, through, again, what have been very difficult times, and I'm sure lots of pressures and all sorts of pressures. But again, Pam, your integrity and your commitment to health, your empathy around health, and your support to me and working along with me, I think has made this the effective committee that it has been. I think it's noticed out there. I think people see it as a positive that members from across a range of parties, and we do have 6 parties on this committee, that members across a range of parties, on behalf of our communities, on behalf of our people, have come in here week after week and worked to try to improve how we deliver health and social care going forward. So I want to thank you for that, Pam. And I see you have an indication there if you want to say a few words yourself, Pam, go ahead. And then I will do a run around members as well if members wish to say anything. So go ahead, Pam.
Thank you, Chair. And can I say it's been a pleasure working with every single one of my health committee colleagues. I think it's been a very good and a very effective team. And I think we've kept the politicking to the absolute minimum, mostly, throughout the last couple of years. And it has been an incredibly pressured time. And it's been a very, at times, a very difficult subject, particularly going through the COVID regs and all those, the impacts of all those. But I suppose I just want to touch on a couple of the bills that we've seen through that I'm particularly pleased about, and that would be the Adoption and Children Bill, the Organ Donation Bill, and also, of course, the Autism Amendment Bill. I think those are 3 very specific ones that I just wanted to mention. I think we can all take pride in the fact that we have seen those through to their completion, and we look forward to the implementation of all of those, which are really vital and really important to everybody out there. So I wanted to say, Colin, thank you for your chairmanship of this committee. I've very much enjoyed working with you, as we have done from day one, and you know, for the sheer volume of work that has been processed through this committee has just been incredible. I mean, I've been here in the Assembly for 11 years, and I've never known so much work on one committee. So I think it has been incredible, and I think absolutely our thanks go to Eilish, who moved on over a year ago, and then to Keith for ably taking over and keeping us right, and the entire committee staff team, who have just, there's not, there's never been a moment where I've thought, well, that wasn't very helpful, or, I mean, we couldn't do our job without the incredible help that we've had, and the team just really deserve a well-earned rest. That committee staff will probably take that opportunity when the Assembly is dissolved to actually get some proper holidays, because we have during recess, I think we've had so many additional meetings, and I know that staff will be very tired, and really I hope they enjoy a very well-deserved rest. But I'll finish with that and just again say thank you and wish all the elected reps all the very best going into the election. We won't be getting much physical rest in the weeks to come, but just to wish each and every one of you all the best, and thank you for your very kind comments, Colin, as well. Thank you.
Thank you, and thank you, Pam. And it does actually remind me of the first two meetings that you and I did as chair and deputy chair, which were then interrupted by the pandemic, and we were no longer able to do that. But the first two meetings, the first one was on contaminated bloods scandal, and the second one was on Donate for Dahi. And I do particularly welcome the fact that both of those issues were eventually addressed in a very positive way. I also think the Adoption and Children Bill, which we have done significant work on, and the Autism Private Members Bill, which you brought, are important pieces of legislation and ones that will I think, bring real change to people who so badly need it. So, and I do think the committee has had significant successes across small items and larger items, and I think that's a product of the fact that everyone took such a constructive approach to it. Paula.
Just very briefly, Chair, just to thank you for your chairmanship, and to the Vice Chair for stepping in, and I think you were a good team, I have to say. And also just want to thank Keith and his staff, because as you outlined there, it was phenomenal, the amount of work. I don't know how they kept going, so just want to place on record my thanks.
Yeah. Deborah.
I just want to say thank you as well. I came in very fresh and new, and I was just laughing earlier. It feels like, I've only just begun and yet I have to go, but I've really enjoyed my term, my time on the Health Committee, and we have had fun, I think, as well, and we have been able to learn a lot. I know I particularly learned a lot in the very short time that I have been on Health Committee, and hopefully we'll be able to continue some of the good work that has went on in this Health Committee. And I really just hope and pray that in the future, some of the issues that have been detailed in our report, that those will come to fruition, and that we will see a difference, and that we will see a change in our health service. I think we owe it to the patients, to the staff that we have been dealing with, that we've been speaking to in the Health Committee. And I think the passion and the commitment that you have talked about, Chair, from each and every member of the committee has really shone through. So I just want to wish everybody well. I hope I see everybody back here again. I hope I'm back here again as well. And I just want to thank the clerk as well, and all the committee staff. They couldn't do more for us, and they are absolutely fantastic. Any questions I had coming in as a new member, they were able to help me out whenever I needed, and so I just want to place on record a huge thank you to them all, because it is really greatly appreciated from us as members. So thank you.
Thank you, Deborah. Carol, I do see a hand up there, but I'm conscious you're having trouble with sound. I'm not sure if that's from earlier or if you wanted to say something at this point.
No, I just like Chair, just wanted to say a couple of fuckles. So while I'm with his watch Disa, I just want to thank everyone. Not to ignore what everybody said. I completely agree with it. I think it is. I mean, today is the last committee, but the presentation from the RCN and the trusts, for me, highlights that unless we can give the proper support over the next months into our frontline staff, and certainly across the health and social care piece, we're all in deep trouble, and we owe them a massive debt of gratitude for people who are just afraid to go to work, continually stepping up and stepping forward. And indeed, I think we've also, as well as the legislation that people have mentioned, I think we've definitely shone a light on some of the scandals that still prevail, because some have reported and others have yet to report. And I think even from some of those individuals and their families, I hope we did them all proud. I hope we were a voice for them on the Statutory Committee. And finally, I just want to wish everybody good luck in the election. He's on the other side, so stay safe.
Yep, thank you, Carol. And just briefly, I'm not sure if we do have, I don't think we have our Leah on the line, actually, at this point in time. So listen, that's all, and actually that's a useful place to end. That was where I was actually looking at. The key thing here going forward is that those people who have been listening in and who have been depending on the committee to play its part in terms of trying to improve the delivery of health and social care, to improve the support and the recruitment and retention of staff, those are the people who my thoughts certainly are going out to as we bring this committee and this mandate to an end. I think it's crucial that we do see a urgent work around those issues being progressed, and the consensus that there is largely in political terms is retained and is deepened and is actioned to a point where we start to actually see that transformation of services on behalf of the public and on behalf of the staff who are out there delivering them. I also want to wish each and every one of you well. To just say, I have to say that I never came into this committee meeting feeling that there was anything other than going to be a positive meeting, even the most difficult of challenges, because your own bona fides in terms of trying to improve health here in the north spoke for themselves and were self-evident throughout the committee. So thank you all, take care, Big Islam, Agus Almore.
Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed.